Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Қайырлы таң, құрметті ханымдар мен мырзалар.
Dear ladies and gentlemen, dear guests, the best of ASCO is welcoming you at this event.
We're glad to welcome you all at the Best of ASCO Kazakhstan 2023 Summit.
Қазақстанда ресми лицензияланған Best of ASCO бағдарламасы қатысушыларымызға онкология саласындағы соңғы жаңалықтардан және таңдаулы мәселелерден хабардар болу үшін бірегей мүмкіндік береді.
Best of ASCO's officially licensed program is a unique opportunity for the participants to be aware about the latest updates and information in the rapidly changing field of oncology.
Best of ASCO Қазақстан 2023 саммитіне Қазақстан, Өзбекстан, Қырғызстан, Азербайджан, Грузия, Беларусь, Ресей, Монголия, ақш, Кувейт, Польша, Молдова мемлекеттерінен 447 қатысушы тіркелген.
447 participants from Kazakhstan, Uzbekistan, Kyrgyzstan, Azerbaijan, Georgia, Belarus, Russia, Mongolia, USA, Kuwait, Poland, Moldova has registered for the Best of ASCO Kazakhstan 2023 summit.
Сөз кезегі Асфендияров атындағы Қазақ ұлттық медицина университетінің басқарма төрағасы, ректоры доктор Шоранов Марат Едігеұлына беріледі.
Dear participants, we would like to bring to your attention the chairman of the board, rector, Kazakh National Medical University named Asfendiarov, Dr. Marat Shoranov. Welcome to the stage.
Қайырлы таң, құрметті әріптестер. Біріншіден баршаңызды осы елімізде
Good day, dear participants. Today is a great day. There is an opening of this summit of ASCO 2023. And today we are welcoming you at the important event for clinicians, scientists, and practitioners. In 2023, the Association of Oncologists of the Republic of Kazakhstan took the initiative to conduct a license program, the Best of ASCO in Kazakhstan.
A very important event. In 2023, the Association of Oncologists of the Republic of Kazakhstan took the initiative to conduct the licensed Best of ASCO program in Kazakhstan. Every year, the ASCO Scientific Committee selects the highest rated abstracts from a list of oral and poster presentations. Following the results of ASCO 2023 conference, a separate country holds licensed meetings of experts. Best of ASCO is an unique event that brings together international and national experts, policymakers, scientists, healthcare professionals, educators, and residents. And of course, it's a great opportunity to get the latest information in oncology. The reports selected for presentation in Kazakhstan were announced at the annual meeting of clinical oncologists in the United States just a month ago. They highlight the results of advanced research and the latest achievements in clinical oncology, which will improve clinical practice, implement new approaches to diagnostics and treatment, and affect the quality of life of our patients. Based on the regional needs of practicing oncologists, it is planned to hold sessions on topical issues of diagnostics and treatment of lung and breast cancer. The format of the event will allow discussing clinical cases, exchanging views with leading foreign experts. Well-known international and domestic experts are invited as speakers. Within 2 days, you will have an opportunity to review scientific reports as well as to communicate directly with the world's leading oncologists and share your experience in the field of cancer treatment. I would like to emphasize my special thanks to Dr. Dilara Kaydarova, the director of the Kazakh National Institute of Oncology and Radiology, and I would like to emphasize my special thanks to the Association of Oncologists of Kazakhstan and for this initiative and organizing this event in Almaty. And I'm pretty much sure that this event will contribute to the treatment, to the improvement of the services provided to our patients, and it will affect quality of services for our patients as well. And of course, it will help us to achieve our ambition goals in the field of cancer control. I would like to, I wish you all these very successful discussions and very successful communications and works. Thank you. Я хотел бы в двух словах еще раз
And also, let me highlight and thank the director of the Kazakh National Institute of Oncologists and Radiologists for this initiative to perform this large event. This is for the first time in Kazakhstan, and I'm sure that during these days, the best presentations that were presented 1 month ago in the USA in the big summit of ASCO. This way, you will get same presentations here to get the newest trends, the latest directions in treatment and diagnostics of the oncological diseases. Let me wish you to have fruitful work. Dear Dr. Marat Sharanov, thank you very much.
Now, our speaker is the director of Yale Cancer Center and physician-in-chief of Smilo Cancer Hospital at Yale New Haven, ASCO President Dr. Eric Wiener.
Құрметті қонақтар, сөз кезегін ASCO президенті, ел онкологиялық орталығының директоры және ел университетіндегі Смилоу онкологиялық ауруханасының бас дәрігері доктор Эрик Винер мырзаға беруге рұқсат етіңіздер. Экрандарға назар аударайық.
Greetings from the Yale Cancer Center and Yale University in New Haven, Connecticut. I'm Eric Weiner, the chair of the board of directors of the American Society of Clinical Oncology. I'm pleased to join you virtually and extend my warmest congratulations to the Kazakhstan Cancer Society and the American Eurasian Cancer Alliance at the opening of the 2023 Best of ASCO meeting in Kazakhstan. This is the first time that a Best of ASCO meeting has been held in Central Asia, and we're very excited to bring the science of the ASCO annual meeting directly to you. Some of you may have joined us in Chicago from the ASCO annual meeting. We very much appreciate the opportunity to welcome attendees from Central Asia to Chicago. At the annual meeting, we had a record number of abstracts of exceptionally high quality. In fact, the number of abstracts submitted for consideration was 7% more than the previous high. But what was most exciting was the number of practice-changing abstracts we heard, including 4 that were presented on the plenary session. My presidential theme for 2023 was partnering with patients, the cornerstone of clinical care and research. In my view, it's vital that professional societies continue to provide oncology professionals with the resources to ensure that they can provide the best possible care. I also believe that by partnering with patients, we not only enhance the care we provide to patients and to their families, but that we also achieve the most meaningful careers for us. In many ways, I believe that partnering with patients is an antidote for what is commonly talked about, that is, burnout in oncology. By partnering with patients, I think we can all have far more satisfying careers. I hope you leave this Best of ASCO meeting much the way people left the ASCO meeting in Chicago, feeling inspired and engaged, excited by the new treatments and what you can bring patients. It is clearly a time when cancer treatment is evolving and very much improving. Thank you for the opportunity to speak with you. Please accept my sincere greetings and congratulations to the leaders and members of the Kazakhstan Cancer Society, and enjoy your meeting. Siva Khoroshiva.
Dr. Wiener, thank you for your involvement and support.
Құрметті қонақтар, сөз кезегін Қазақ онкология және радиология ғылыми зерттеу институтының басқарма төрайымы профессор академик Қайдарова Диляр Радикқызына беруге рұқсат етіңіздер. Диляр Радикқызы осы жылы Азия және Океания бойынша ASCO халықаралық істер комитетінің мүшесі атанды.
Dear guests, please welcome the chairman of the board of the Kazakh Research Institute of Oncology and Radiology, Professor, the academician of the Academy of Sciences, Dilara Kaidarova. This year, she became a member of ASCO International Affairs Committee member for Asia and Oceania.
Құрметті әріптестер, қатысушылар және біздің қонақтар, сіздерге біздің ASCO ашылуға конференция қош келдіңіздер. Сіздерге баршаңызға
Dear ladies and gentlemen, welcome to this summit, Best of ASCO 2023. We are very much glad to see you.
2023 international conference. It is an honor for us to be the host of such a high-level event. Thank you for all coming and good luck. Я перейду на русский, потому что у нас перевод идет русский.
So actually the interpreting is provided.
В этом году впервые
So this year it is for the first time Best of ASCO performed in Kazakhstan, in the Republic of Kazakhstan. This platform of Kazakhstan is chosen not only for the country of Kazakhstan, but for the whole Central Asia. More than 30 countries registered to participate in this event. 1 month ago, the Best of ASCO took place in US with the 300 oncologists. Different lectures and abstracts were presented there, and ASCO permitted us to present it here. This is a great opportunity for our oncologists, for those who could not visit the Congress in Chicago, US. Sometimes people don't speak English, but these 2 days of this seminar will let us know the best approaches to treat the breast cancer and lung cancer, because both of them take first place in Kazakhstan. Annually, more than 49,000 new cases registered, and out of them, 4,000 are lung cancer, 5,000 breast cancer new cases registered annually. That's why we have chosen those topics this year, in order to improve the diagnostic methods, treatment methods, and new approaches to those two nosologies. And let me thank our speakers who managed to come in summertime, vacation time, who took the opportunity to fly here. And today you will see the newest abstracts allowed to present by ASCO. Let me wish you to have a very successful first summit of ASCO. Hopefully the first, not the last one, because we have lots of plans. I'm the chairman of the board, and I hope that many programs and agendas, they will be dedicated to our regions as well, and jointly with many other countries, we will arrange ASCO summits in other countries as well. Let me wish you to have success and fruitful work. Today is a very hectic day. Not just lectures, but also it will be an interactive event. So first lectures, and then to improve your knowledge, we will have Q&A sessions. So today we have different experts, pathomorphologists, radiologists, surgeons, and chemotherapists. They are all here, and all the approaches that should be improved and changed, not only in this country, but in other post-Soviet countries, in order to improve the medical services quality. Thank you very much for your attention, and let me wish you to have fruitful work. We thank Dilara Radikovna for her speech.
Executive Director of the American Eurasian Cancer Alliance, Dr. Sophia Michelson. Please bring your attention to the screens.
Келесі сөз кезегі Америка Еуразиялық онкологияға қарсы альянстың атқарушы директоры доктор София Майклсонға беріледі. Экрандарға назар аударайық.
Dr. Sophia Michelson, please turn on your microphone.
Thank you. Thank you. Good morning, everybody. Today is absolutely wonderful day, not just because it's best of ASCO. It's only from my perspective what I'm anticipating to have best of Kazakhstan at ASCO. I will start with a small history of how it all started and how we will be progressing further. Since 2014 or 2015, one of these years, National Cancer Institute, together with American Eurasian Cancer Alliance that I represent, started an initiative with ASCO Global to introduce Central Asia as a region where a lot of programs can be conducted by all the partners. American Eurasian Cancer Alliance unites leading comprehensive cancer centers of the United States, as well as leading societies. One of them is American Society of Clinical Oncologists. However, the road to introduction was very long. Since 2016, it took many years until we finally reached what I call a complete recognition of your region, by not only conducting today's important, most updated, and very relevant to your region event, but also by bringing your country as one of the only 19 countries in International Committee of American Society of Clinical Oncologists. American Society of Clinical Oncologists exists since 1964. Out of 130 countries that represent global community, only 19 are chosen to lead that global community in international vision of cancer control. Imagine that this year, Kazakhstan become one of these 19 countries that is represented right now in that very panoramic international vision. I very much appreciate your consideration and very much appreciate the fact that Dilara Kaidarova will represent this particular, not only this particular event, not only this particular program, but the whole country in the arena of ASCO. So I wish you everybody, first of all, the best of health. And from my standpoint, I consider it's a big win. And also from my perspective, I consider it a first significant event with many, many to come. I appreciate your attention, appreciate your support, and I know that I will be standing by your side from now on. Thank you so much. Bye-bye.
Dr. Michelson, thank you for your valuable contribution.
Құрметті қатысушылар, бүгін саммиттің бірінші күні сүт безі қателесігінің тақырыбына арналған. Түске дейін сүт безі қателесігі тақырыбында клиникалық ғылыми симпозиум өтеді. Ертеңгі күн өкпе қателесігі тақырыбына арналады.
Dear participants, the first day of the summit is devoted to the topic breast cancer. This morning there will be a clinical science symposium breast cancer. Tomorrow's day will be devoted to the topic lung cancer.
Түскі ас қонақ үйдің бас ғимаратында, кофе брейктер осы ғимараттың бірінші қабаты көрме аймағында өтеді.
Lunch will be held in the main building of the hotel. Coffee break on the first floor of this building in the exhibition area.
Құрметті саммит қатысушылары, бүгін және ертең әр баяндама басталмас бұрын және аяқталған соң онлайн викторина өткізіледі. Онлайн викторинаға экрандарда көрсетілген QR-кодты сканерлеу арқылы қосылуға болады. Жауап беруге 3 минут уақыт бөлінетінін ескеріңіз.
Dear participants of the summit, today and tomorrow, before and after each report, an online quiz will be held. It will be possible to connect to the online quiz using QR codes that will be displayed on the screens. Please note that you have 3 minutes to answer.
Құрметті қонақтар, осымен саммиттің ашылу салтанаты аяқталды. Алдағы 2 күннің сіздер үшін нәтижелі болатынына сенімдіміз. Іске сәт.
Dear guests, this is the end of the open ceremony of the summit. We are sure that the next 2 days will be productive for you. Good luck.
Құрметті Марат Едігеұлы, Диляр Радикқызы және Ирахлия Куклидзе мырза, сүт безі қателесігін клиникалық ғылыми симпозиумға модераторлық ету үшін подиумда қалуларыңызды өтініп сұраймыз.
Dear Marat Shuranov, Irakli Kokhriidze and Dilara Kaidarova, we kindly ask you to stay on the podium for the moderation of the Clinical Science Symposium Breast Cancer.
Құрметті қонақтар, баяндамалар барысында спикерлерге сұрақтарыңыз болса, спикер сөзін аяқтаған соң қолдарыңызды көтеріп, микрофонның әкелуін күтуіңізді өтініп сұраймыз. Рахмет.
Dear guests, in case you have any questions for the speakers during the report, please raise your hand and wait for the microphone to be brought. Thank you.
Yeah.
Модераторлықты...
Модераторы здесь уже сидят. Орны. Поменяйте это? Куда его?
Dear ladies and gentlemen, dear colleagues, dear Dilara, it's a great pleasure and honor to be here and to have the first session, which is dedicated to late recurrence in ER-positive breast cancer. It's a great honor for me to be here with you. Thank you very much. Уважаемые коллеги, в первую очередь я начну, наверное, у нас интерактив, и с этого интерактива мы начнем первую лекцию, которая посвящена вопросам рецидивирования рака молочной железы. Есть у нас вопросы или нет?
Нужно навести, да, на QR, телефон, навести на вот этот QR, который у вас на телевизоре. У вас в телефоне должны появиться вопросы. Я проверю сама. И надо... Кто будет вопросы? Оксана Владимировна, есть?
So, who is going to make questions?
Выбрать язык надо.
So
да,
you
здесь есть и на русском, и на английском.
It's available in English and Russian.
Тогда как мы сделаем? Я дам вам, да?
Я попробую прочитать первый вопрос. Patient with ER-positive HER2-negative breast cancer. Imagine the appropriate duration of endocrine therapy for stage 1 disease. What is your opinion?
Здесь вопросы, три ответа. У пациентки
So there are 3 answers suggested. A patient is having a positive HER2 cancer, breast cancer. The first stage, what kind of clinical therapy you would choose? Please choose one of 3 answers. The next question.
Patient with ER-positive HER2-negative breast cancer, the appropriate duration of endocrine therapy for stage 3 disease. То есть пациентка с ER-позитивным, HER-негативным раком третьей стадии, какая длительность, оптимальная длительность адъювантной гормонотерапии? Это 5 лет, 7, 8 лет и 10 лет. Это второй вопрос.
Это третьей стадии там.
So that was the third stage.
Следующий вопрос.
И следующий вопрос, which of the following statements is false, not true, false. luminal breast cancer has small and long-term risk of disease recurrence. More than 15% of relapses occur after 5 years. Luminal breast cancer has small but short-term risk of disease recurrence. More than 50% of relapses occur after 1 to 2 years. And extended endocrine therapy is optimal for patients at increased risk. У нас вопрос, который неправильный. То есть люминальный рак молочной железы имеет малый
So we should find the false answer. The luminal breast cancer has small but short-term risk of disease recurrence. More than 50% of relapses occur after 1 or 2 years. So other risks are, there is a short-term risk, more than 50% of relapses occur after 1-2 years. During 1-2 years of treatment. Or, third possible answer, extended endocrine therapy is optimal for patients at increased risk. So there are 3 possible answers. One of them is false. Which of the statements are false?
Так.
Секунд.
In 30 seconds, we will have an answer.
Будут ответы. Сама академик мне наливает воду.
So the academician is serving me the water. So now let's check which statement is false and what are the answers. What are the correct answers? So 70% voted that the first answer should be 5 years. Means the endocrine therapy for stage 1 is 5 years. Yes, it's absolutely correct.
28% за 5 лет,
28% voted for 5 years,
31% за 10 лет.
31% voted for 10 years. So this should be discussed during our lecture. So shall we know the correct answers later on? When we will know the correct answers? By the end of the lecture. So we will double check and we will see which way you perceive the lecture. And the question number 3, which of the following statements is false? So very different answers, no unity. 27% voted for the first statement. So this is the way you treat the patients. This is the way I understand it. So now we will reveal who is doing that correct and who not.
Хорошо, наверное, все-таки лучше начать, потому что, как мы видим, абсолютно разные ответы мы получили на эти 3 вопроса. И мы встречаем этих пациентов, мы лечим этих пациентов, поэтому мы должны все-таки быть однородными в наших решениях с учетом рекомендаций ASCO и результатов рандомизированных исследований.
And here are the results from the best of ASCO.
My talk is about late recurrence in ER-positive breast cancer. What else can we do? Как? Куда? Что делать?
Кнопку покажи.
Понятно. So this presentation was modified with love and great pleasure from Georgia, ancient country on bridge between Europe and Asia, and unfortunately 20% of my country is still occupied by Russia. So, as you know, after 4 years and one virtual event due to the pandemic, more than 800 participants from over 100 countries came together in Vienna, and the 2023 St. Gallen Vienna conference was a great success. Over 3 days, the global faculty reviewed the most important evidence published during the last 2 years and debated over controversial topics. And finally, the consensus votes aimed to define the impact of the new data on everyday routine practice. So which of take-home messages do we have from the 18th of St. Gallen Breast Cancer Conference? First of all, luminal breast cancer has a small but long-term risk of disease recurrence. More than 50% of all disease relapse occur after 5 years. Extended endocrine therapy is beneficial for patients at increased risk. 7 to 8 years treatment duration is optimal for most of our patients. Treatment adherence is important. Carry over effect, recently reported benefits of adjuvant therapy could translate into long-term improvements. Identifying patients at increased risk for late relapse is an important research goal. If we can also show that we can intervene with the late treatment. Women with early-stage breast cancer today are 66% less likely to die within 5 years of diagnosis than they were in early 19s. Previous study has showed that the breast cancer survival rate has improved as the risk of death after being diagnosed with invasive breast cancer has decreased over the past few decades. Breast cancer subtypes are associated with different time and pattern of recurrence, and it should be considered during treatment decision. The luminal A subtype has the highest 10-year survival, followed by luminal B and luminal and HER2. The worst survival demonstrate HER2 enriched and triple-negative breast cancer. So the first take-home message is that more than 50% of all disease relapse of luminal breast cancer, luminal A breast cancer, relapses occur after 5 years. As we know, there is the 14% of recurrence risk reduction by adding the tamoxifen to treatment strategy compared to control placebo group of patients, and about 20% of these benefit by extended treatment from 2 to 5 years. We also have EBCG trial main findings, and first of all, in breast cancer patient, risk of recurrence continues steadily to at least 20 years after 5 years of endocrine therapy, and second, absolute recurrence risk in years 5 to 20 is appreciable even for T1 and 0 breast cancer. Another study is GYM4. In postmenopausal patients with breast cancer who received 2 to 3 years of tamoxifen, extended treatment with 5 years of letrozole resulted in significant improvement in disease-free survival compared with the standard 2 to 3 years of letrozole. So sequential endocrine therapy with tamoxifen for 2 to 3 years followed by letrozole for 5 years should be considered as one of the optimal standard endocrine treatment for postmenopausal patients with hormone receptor positive breast cancer. The benefits and potential risks of extended adjuvant therapy by aromatase inhibitors 5 years from different clinical studies are presented on slide. It has been also proven that in postmenopausal women with hormone receptor positive breast cancer who had received 5 years of adjuvant endocrine therapy, extended hormone therapy by 5 years provided no benefit over a 2-year extension, but was associated with a greater risk of bone fracture. ABCSG 16 subgroups by age, tumor stage, nodal status, and other characteristics are presented on slide. Patients with breast cancer and N-positive disease can obtain a significant disease-free survival benefit from the full extended as compared with the limited extended adjuvant endocrine therapy. The full extended endocrine therapy provides no disease-free survival benefit as compared with the limited extended endocrine therapy in patients with N-negative disease. Back to the St. Gallen Consensus Conference, where Harald Burstein elegantly moderated the discussion and led the panel through the consensus and the voting. A substantial proportion of questions had already been voted on by the panel in advance, and the results were shown during the panel discussion as more controversial and urgent topics were prioritized for discussion. So, first question was for the treatment of patient with hormone positive and who had 2 negative stage 1 disease, and 88.2% of panelists vote for 5-year duration of endocrine therapy. So, примерно такие же результаты у нас были и сегодня.
Roughly the same results.
The second question, in
HER-positive,
HER2 negative stage 2 node negative breast cancer, 44.9% of experts voted for 5 years duration of endocrine therapy and 36.7% for prolongation of treatment. It's necessary to underline that just about 12% of votes went for identification of high and low risk groups of patients depending on the future biological factors. And for patients with ER-positive, HER2 negative stage 2 node positive disease, 68% of panelists voted for 7 to 8 years of endocrine therapy and only 24 for full extended treatment. And last, in case of stage 3 disease, majority of panelists voted for fully extended 10 years of endocrine treatment. Extended endocrine treatment is beneficial for patients at increased risk, and 7 to 8 years of treatment duration is absolutely optimal. For postmenopausal women with hormone receptor positive breast cancer, the most effective duration for adjuvant therapy with the aromatase inhibitors remain unclear. In this prospective phase 3 trial, authors randomly assigned postmenopausal women with hormone receptor positive breast cancer who had received 5 years of adjuvant endocrine therapy to receive the aromatase inhibitor anastrozole for an additional 2 years, and secondary endpoints were overall survival, contralateral breast cancer, second primary cancer, and clinical bone fracture. In postmenopausal women with hormone receptor positive breast cancer who had received 5 years of adjuvant endocrine therapy, extended hormonal therapy by 5 years provide no benefit over a 2 years extension, but was associated with a greater risk of bone fracture. The risk of clinical bone fracture at 5 years after randomization was lower in the 2 years group than in the 5 years group. In postmenopausal women with hormone receptor positive early stage breast cancer, treatment with adjuvant aromatase inhibitors is the standard of care, but it increased risk of osteoporosis also. Results from the ABCSG 18 trial showed the use of denosumab as the adjuvant to aromatase inhibitors therapies significantly reduced clinical fractures and osteoporosis. After a median follow-up of 73 months, disease-free survival was significantly improved in the denosumab group versus the placebo group. And in the denosumab group, disease-free survival was 89% at 5 years and 80% and 8 years of follow-up, compared with 87 at 5 years and 77 at 8 years in the placebo group. So treatment adherence is very, very important. What about the carryover effect of adjuvant tamoxifen? The primary aim of this study, or the meta-analysis of the different randomized clinical trials, was to compare 2 years of adjuvant tamoxifen versus no systemic treatment in premenopausal patients with ER-positive tumors regarding breast cancer-free interval and distant recurrence-free interval, with 30 years of follow-up and for specified intervals. Moreover, authors remind to investigate the effects of adjuvant tamoxifen on the incidence of secondary malignancies and survival after the distant recurrence. With 3 decades of follow-up, 2 years of adjuvant tamoxifen reduced the incidence of breast cancer-related events and distant recurrence, and the carryover effect seems to be extended beyond 15 years. As the highlights, we can underline the main conclusions. 2 years of tamoxifen reduced breast cancer events also after 30 years of follow-up. For ER-positive breast cancer patients, the carryover effect was evident beyond 15 years. ER-positive patients treated with tamoxifen had shorter survival after distant recurrence, and tamoxifen was associated with a percent reduction of contralateral breast cancer. So, carryover effect, recently reported benefits of adjuvant therapy could translate into long-term improvements. What about the true target? So, many cancer patients suffer from metastatic relapse. After years, they have undergone radical surgery. Early cancer cell dissemination followed by a protracted period of dormancy potentially explains this prevalent clinical behavior. Increased evidence suggests that the metastatic initiating cells are cancer stem cells or revert to the functional state upon infiltrating a target organ. They entry into dormancy and subsequent reactivation and governed by intrinsic programs and by contextual causes which resemble those regarding the self-renewal capability of the adult stem cells. In addition, metastatic cells undergo reactivation, are nursed by specialized extracellular matrix which support positive signals, which are WNT, VNT, and Notch, and attenuate negative signals such as BMP. In the spite of significant remaining uncertainties, these findings provide a framework to understand the logic of metastatic dormancy and reactivation and open new perspectives for the therapeutic interventions. Authors examine the dynamics of circulating tumor DNA in plasma of high-risk early-stage breast cancer patients receiving neoadjuvant chemotherapy. Understanding the predictive and prognostic value of ctDNA and biology of ctDNA shedding in different breast cancer subtypes can inform the use of ctDNA for treatment selection to improve patients' outcome. Circulating tumor DNA analysis may improve early-stage breast cancer treatment via non-invasive tumor burden assessment. To investigate subtype-specific differences in the clinical significance and biology of ctDNA shedding, authors perform serial personalized ctDNA analysis in hormone receptor positive, HER2-negative breast cancer and triple-negative breast cancer patients receiving neoadjuvant chemotherapy. So, ctDNA positivity rates before, during, and after neoadjuvant chemotherapy are higher in triple-negative breast cancer than in hormone-positive or HER2-negative breast cancer patients. Early clearance of this ctDNA 3 weeks after treatment initiation predicts a favorable response to neoadjuvant chemotherapy in triple-negative breast cancer. Pretreatment tumor mRNA profiling reveals association between ctDNA shedding and cell cycle and immune-associated signaling. So, identifying patients at increased risk of late relapse is an important goal for us, for our everyday clinical practice. Here is the ending. So, we have the main topics and take-home messages from the St. Gallen Breast Cancer Conference. Thank you very much.
Опять, да, повторный идет, не голосование, как это сказать, проверка, закрепление знаний. Как вы усвоили эту лекцию? Что было до этого? И теперь сейчас наши техники включают. И такой старт. Начинаем. Стартуем, да? Еще раз проверяем свои знания.
So, patient with ERP-positive
So we are checking your knowledge.
Duration of endocrine therapy for stage 1 disease is.
Теперь легко уже всем, да? Надеюсь, ответы будут одинаковые.
We hope that right now it's much more easier to answer, and the answers will be homogeneous.
Следующий, да? Второй вопрос.
ERP-positive HER2-negative breast cancer, the appropriative duration of endocrine therapy for stage 3 disease is.
Второй вопрос.
And the third one, which of the following statements is false? Luminal breast cancer has small and long-term risk of disease recurrence. Luminal breast cancer has small but short-term risk disease recurrence, more than 15% of relapse.
Answering as a correct statement, but in this task, you should choose the false statement, please.
Будет полегче нам.
I hope it's much easier for you. So we are on time. We are okay with the time.
Значит, ответы на первый вопрос.
So the answer for the first question.
У нас идет обработка.
Now the system is processing the answers.
И опять у нас
абсолютно правильно.
So the majority, 74%, voted that there is a second answer. 5 years. This is the optimum duration for endocrine therapy for stage 1 disease.
6%
So
так и не
still
усвоили
26% missed the material.
26% сидящих в этом зале, то есть каждый четвертый, не усвоил этот материал. Еще раз запомните правильный ответ при первой стадии. HER2 negative breast cancer, РПР positive, 5 лет гормонотерапии. Запишите, пожалуйста, у нас будет там home message, домашний, как эти тезисы для дома.
This is a take-home message. So, second question, same thing. So the question was the patient with ER/PR positive, HER2 negative breast cancer. This is a very disputable answer, but 65%, the majority answered correctly, that 7-8 years, this is the most adequate treatment for the third stage
Опять те же, теперь 30.
This is a very disputable question. So it's up to discussion. If you would like to dispute, please take a microphone. If everybody would like to argue, you are more than welcome. Please, professor from Georgia.
Good morning, dear colleagues. So I would like only clarify for third stage of the patients. We always keep in mind they are premenopausal or postmenopausal. If they are postmenopausal, okay, 7 and 8 years, it's okay. But if they are premenopausal, we prefer to prescribe the tamoxifen during 10 years. It's my suggestion.
Yes, tamoxifen, and then by the aromatase inhibitors. 5 years.
If we switch to aromatase inhibitors and they are still premenopausal, we need to add LHRH plus aromatase inhibitor.
Okay.
Спасибо.
Да, вот большое спасибо, абсолютно правильно, да.
Yes, thank you very much. We absolutely agree. If there is a premenopausal patient, we believe that the most adequate duration is 10 years. But we got such answers. This is the way it is.
False, и у нас абсолютно правильный ответ, 74%.
The majority answered correctly. 74% of participants answered that luminal breast cancer is characterized by 50% of relapses that occur after 1-2 years of treatment. So again, the rest of participants did not perceive this material. Please take notes, please memorize this information. So this case is not disputable. So this is the risk of a relapse, is prolonged risk. This is the way it looks like. Pity to say that treatment of such patients is very difficult. This is a fatal problem. Please remember that. So, in such patients, we believe we should identify new molecules, new targets, and also probably there are some genetic issues in case during the first stage there is already a relapse in 1 or 2 years. In case of the luminal breast cancer. If you have any questions, we can continue our interactive session. We have time. We have time for Q&A. Maybe later. You take time to think it over. Thank you, Irakli.
А где наши дети? Я доведу. Следующий доклад у нас профессор Джанкарло Прунери, профессор Университет Милан.
He is pathologist from Milano University, Medicine School of Italy. This is the association of the tumor-infiltrated lymphocytes.
Characteristics and prognosis in young women with positive HER2 отрицательная breast cancer. HER2 breast cancer. И профессор Прунери, он подключается у нас, да?
Professor Pruneri is getting connected online.
Он нас слышит, да? И сейчас что мне? Вы что мне?
Can you hear us, dear professor? Could you please let us know? Could you please turn on your microphone because we cannot hear you?
Giancarlo, how are you? Please turn on your...
I can hear you. Can you hear me?
Yes. Yes, at the moment. We're so glad to see you.
Can you tell me if you can hear me?
Yes, Giancarlo, we can.
Ciao. Okay, you can hear me.
Yes.
Fantastic. And you can see the slide as well?
Oh, yes.
Okay, that's great. Thank you. Thank you so much. Sorry for being a bit late. Let me just thank you, you all, for inviting.
Sorry, we don't see your slides. Could you please?
Let me see whether I'm able to show you the slides, but you should see the slide, but let me see.
Yes, it is okay. Thank you.
It's okay now? Okay, that's great. So again, thank you for inviting me at the Kazakhstan Cancer Society Congress to the Best of ASCO. I would especially like to thank Professor Dilara Kaidarova and all the ASCO representatives. So today, my duty is to talk about this paper. This is a paper, the title of the paper is the Association of Tumor Infiltrating Lymphocytes, TILS, with clinical pathological characteristics and prognosis in young women with HR HER2 negative breast cancer. So this is a very, focused paper on a very special setting, as the authors properly...
Giancarlo, excuse me, can you hear me?
Yes, sure.
Excuse me, before your lecture, we have the interaction, we have the some kind of interactive answers.
The questions, sorry.
Yes,
sorry,
the questions.
Yes.
So we have the questions. Can you see them or not?
No, but I have the question on my PC.
Perfect. Perfect. So the audience is scanning these questions, and we will have the answers in short time. So excuse us for interrupting you.
No problem at all. So let me just... should I read the question now?
Yes, it will be great.
Absolutely, absolutely.
It will be great.
Yeah, sure. Let me just retrieve it. Okay, this is the first question. The first question is what TILs are? And the possible answer are TILs are prognostic and predictive marker. High level are associated with a poor prognosis and equal or more than 3 residual cancer burden, residual disease. The second is TILs are prognostic and predictive markers, high level associated with improved survival and PCR pathological complete response. And the third is TILs are diagnostic markers which shows expression of ER, PGR in tumor samples. So this is the first question. You're expected to vote now.
No, at the end of second and third question. So can you also read the second question and the third question?
Sorry, but I have just the first. Sorry, but I have just the first question, I think.
So I can continue.
No, maybe this is the second question. Which of the following statement is false?
This is third question.
Okay. No,
okay.
Sorry. I retrieved the second as well.
So what subtypes of breast cancer?
What subtype of breast cancer associated with high level of TILs? It's luminal A, luminal B, HER2 enriched, or basal-like. And the third question is, which of the following statement is false? High cytotoxic T-cell expression in tumor associated with improved overall survival. The question, remember, is false. It's not true. High T helper and T regulatory cell expression associated with the reduced breast cancer-free survival and distant disease-free survival. And the third answer is high PD-L1 status of tumor associated with improved breast cancer-free survival and distant disease-free survival.
Okay, we have the results of voting in audience, so can we see the results?
Let me just see if I'm able to see the results.
Can you see?
No. Yes.
Okay,
sure.
so 40% of votes went to A, 49 to B, and 11 to C. And the answers of the second question, please.
Yes.
The second, the results
Yeah.
are very different.
Yes, they are
No,
quite.
non-harmonic.
Yeah, sure.
And the third one.
And the third, they are heterogeneous as well. Okay, surely the third question is related to the content of the study that
Yes.
I'm going to present. So it's quite, expected that they are heterogeneous. Probably we have to comment the answer at the end of the presentation. Is it correct?
At the end of your presentation, we will have the revoting process.
Revolt, sure. Revolt and comment. Sure,
Yes.
absolutely.
Yes. Yes. Thank you.
Thank you so much. Are you able to see the slides now?
Yes. Yes.
Okay.
We can
Great.
see. Yes.
Okay, that's fantastic. So, as we mentioned before, this is a study that is related on a very specific setting. As you see, it's a young women with hormone receptor positive tumors. And as the author properly underlined, young patients with hormone receptor positive breast cancer, they have inferior long-term outcomes. This is in general, of course, and the authors stated that patients diagnosed with breast cancer at age less than 40 years, they have a worse prognosis than older patients. And this is particularly true in hormone receptor positive disease. To what extent this risk stems from age-related biological differences is poorly understood, as we know, and of course biomarkers are needed in order to tailor treatment for young patients with hormone receptor positive breast cancer. And as you see here, in these curves, this is the prognosis of patients aged less than 40 years at diagnosis, and you see that the prognosis is significantly worse than for patients we aged more than 40 years. So we know very well that TILs are associated with improved prognosis, including young patients. But this is particularly true for patients with triple-negative breast cancer, either at the early stage or in the locally advanced setting. And the authors showed this paper that was published by our group. The first name was Sherin Loy, that untreated triple-negative breast cancer patients aged less than 40 years with a high stromal TILS contact, they have an excellent long-term prognosis that you see here in this Kaplan-Meier. So what are TILs? The biological significance of TILs, especially in the hormone receptor positive breast cancer setting, it remains unclear. So there are studies evaluating TILs in hormone receptor positive breast cancer. They are limited and the results, they are heterogeneous. This means that if you see the literature, you will find that in hormone receptor positive disease, TILs have been associated to a worse prognosis at variance with triple-negative breast cancer or with a better prognosis. So the results, they are very heterogeneous in this specific setting. And this is why this paper was so important that it was presented at ASCO, because the setting of the HR-positive breast cancer, this setting is still unclear with regard of TILs. And this may, from a biological point of view, this may due in part of the inadequate understanding of HR-positive tumor immune microenvironment, including the significance of immunostimulatory versus immunosuppressive T subtypes. So you know very well that the balance between the immunostimulatory TILs and the immunosuppressive TILs. This is very important in order to understand whether TILs are associated or not to an anti-tumor response. So the authors, they asked whether whether or not young age should impact breast tumor microenvironment. And the prior research was were predominantly focused on older patients, and the young patient possessed potentially significant age-related host and tumor differences that could alter the tumor microenvironment. So these are the objectives of the study. The study was carried out in order to characterize the extent and the composition of immune infiltration in HR-positive tumors of young patients. The second endpoint was to assess differences in TIL subtypes according to clinical pathological characteristics of young women with HR breast cancer. And the third was to determine the impact of TIL subtypes on invasive breast cancer-free survival, distant disease-free survival, and overall survival of young women with HR-positive breast cancer. So the study population was composed by the patients recruited within the Young Women's Breast Cancer Study. It was a prospective cohort of women diagnosed with breast cancer at age less or equal to 30 years. And the patients were enrolled between 2006 and 2016 from 13 sites in the US and Canada. You see here that the authors started from 1,300 patients, and then they excluded the patient ineligible post-enrollment or the consent withdrawn. And then they also, of course, excluded the patients with very advanced tumors or with in situ disease, the patients which were ER and PR negative, the HER2 positive, or the patient with a missing status, the patient subjected to preoperative therapy, or with bilateral invasive breast cancer. At the end of the day, they end up with more than 400 patients, but then there were no available banked tissue microarray tissue, the tissue within the microarray, or the poor tissue microarray sample quality. This is very important. The authors used a tissue microarray which, as you know, they are the small pieces of tumors which are collected within just one slide, and this is very important when you are using multiplexing immunofluorescence or immunohistochemical study. So the study was based on more or less 400 patients, and these were the subpopulation of T cells which were evaluated by the authors. They evaluated cytotoxic T cells, T helper cells, T regulatory cells, the exhausted T cells, and PD-L1 cells, and they did that by using a combination of CD8, CD3, FOXP3, and PD-1 and PD-L1 biomarkers. So these are the characteristics of the patients under study. You see that, of course, as expected, all the patients were aged less than 40 years, and this was the distribution with quite a larger group of patients from 36 to 40 years.
Recording in progress.
Let me just underline the fact that the authors also collect data on the time since the last pregnancy, and of course this is very important, the genetic testing, so the BRCA status, and you see that the population was quite balanced between BRCA1 and BRCA2 positive tumors. This was the stage, the HCC stage. You see that most of the patients, they were more than 80% of the patients that were in stage 1 or 2. More than 63% of the patients they were with and without any kind of lymph node involvement. And as expected, because the population is composed by young patients, most, it was not most, but because most were grade 2, but there was quite a large population of patients with grade 3, so fully differentiated tumors. And more than 60% of the patients, they received a chemotherapy within the adjuvant setting. And of course, this is quite interesting in my opinion. You see that despite the fact that the patients were HR positive, just 77% they received an endocrine therapy after their diagnosis. So these are the results. You see the TIL subtype distribution, and you see that the others collected the distribution within the stroma or within the tumor. And for sake of clarity, we will focus especially on, the distribution within the stroma, because as you probably recall, TILs were, defined originally as lymphocytes within the stroma surrounding the neoplastic cells, so the specialized stroma of the tumor. But when we decided that the guidelines for defining TILs, we defined TILs as a population of lymphocytes within the stroma. So of course we will take into account also what happened in the tumor, but in my opinion it is very important to focus on the stroma. You see that of course, there were the population, and you see that there were very high content of cytotoxic T cells and also PD-L1 cell within the stroma and also within the tumor. You see that the distribution, they were quite similar. So older patients, the author find out that older patients, they have a higher expression of certain T subtypes in stroma and tumors. You see the cytotoxic T cells, the author split at the breakdown according to the age of the patients, and you see that the population, the prevalence of cytotoxic T cells, it was quite higher in the population approaching 40 years than in the patients, in younger patients, and this was significant. The same was for exhausted T cells and for T helper cells. And you see that, there was a quite higher distribution within the stroma for CD8 positive lymphocytes, according to the aging of the population. So this is something that the authors found according to the ethnicity, and they found that Afro-American patients, they had higher stromal expression of cytotoxin and T regulatory cells, and this is quite expected if we consider what was already published for triple-negative breast cancer patients, that, as you know, they have a higher content of TILs in Afro-American than in Caucasian patients. The authors also found that the aggressive histological subtypes, they had a higher T helper cell expression, and you see that the so-called more aggressive histological subtypes, they are the metaplastic or micropapillary tumors. Of course, I would agree with the definition of metaplastic, of course, as an aggressive subtype. The micropapillary subtype is, has not been demonstrated as an intrinsically more aggressive subtype in breast cancer. And let me just underline the fact that we are talking about hormone receptor positive tumors, and probably the definition of metaplastic carcinoma is not that proper, at least in my opinion, because usually metaplastic carcinoma, they are ER positive, so negative, so they are estrogen receptor negative, but in this case, they were supposed to be positive. But yet, at the end of the day, the main message here is that according to the histological subtype, the author found out that the more aggressive tumor they had, higher TLP expression. The authors also found that high-grade tumors, they have a higher immune marker expression in general, and this is happening for the cytotoxic, T-regulatory, PD-1, and so on. You see that according to the grade, the histological grade, there was a higher content of cytotoxic T cells and regulatory cells, and also PD-1 cells. This is not, completely unexpected because, what we know is that TILs, they are a biomarker of, mutational tumor burden in general and the neoantigen formation. So the higher the histological grade, probably the higher is the complexity of the mutational landscape of a tumor, and so the higher is the anti-tumor response. So these results, which were for the first time presented for HR positive tumors, they are, agreeing with a more general idea that higher histological grade is associated with a higher content of TILs. So then the author found no association of TIL subtypes with other patient characteristics. Let me just underline the fact that TILs in the past have been associated with the BRCA1 and 2 mutation. In this case, in this specific study, the author did not find any kind of association, but this is probably because the prevalence of BRCA1 and 2 mutated patients, it was very, very low. And these are the results related to the survival. That was probably the primary endpoint of the patients. And you see here a table with regard to the multivariate survival analysis by continuous 10% increase in TILs as evaluated by the immunofluorescence and not hematoxylin and deoxin. And so this is a very complex table. So let me just read the statement of the authors. They found that the high cytotoxic T cell expression, it was associated with improved overall survival. This happened just for the evaluation in the tumor. They also found that high TLP cell expression was associated with improved invasive breast cancer-free survival, either in the tumor and in the stroma, and distant disease-free survival. This is just for the tumor. They also found that the high T regulatory cell expression was associated with improved invasive breast cancer-free survival, stroma and tumor, and distant disease-free survival just in the tumor. And finally, they also discovered that the high PD-1 expression was associated with improved invasive breast cancer-free survival, stroma and tumor, distant disease-free survival, stroma and tumor, and overall survival, tumor only. So, in general, what the authors found, it was that irrespective to the type of TILs, the higher the content of TILs, and the better was the survival. Of course, the signal they found it is not very, not very important, and you see that they found heterogeneous data. So they found that these were associated with improved survival in tumor or in tumor and stroma. So the signal is there. Is not that important, but this is probably because the population is quite is quite small, so it is probably underpowered to address final conclusion. But of course, this is a hypothesis-generating study, in my opinion, that is suggesting that TILs are associated to an improved survival in young patients, also in the HR-positive setting. The others probably underline the study limitation, the potential for tissue and biomarker heterogeneity in tissue microarray. As I mentioned before, tissue microarray, they are evaluating very small part of the tumors. So of course, according to the intratumor heterogeneity, they could not be the perfect tool for investigating the subpopulation, the lymphocyte subpopulation. Probably, they underline that probably, the method, the multiparametric immunofluorescence and the quantitative image analysis probably could be not the best method for evaluating. They are not being validated in the past. Of course, they decided, they pre-specified not to investigate some specific subset of lymphocytes. For example, the B cells were not included in the analysis. The biomarker analysis was not corrected for multiplicity due to the explorative nature and retrospective nature of the study. There was no adjustment for ER expression level or endocrine therapy received, and lack of older patients that aged more than 40 years as a comparison group in the HR positive population. But the conclusion of the others was the T subtypes in young women, HR positive tumors varied according to age, race, histological subtype, and grade. Most T subtypes, including immunostimulatory and immunosuppressive, were associated with improved breast cancer outcomes in young patients. It may reflect an overall favorable effect from active anti-tumor responses and concomitant immunoregulatory cell infiltration as a part of a normal feedback loop. The characterization of immune cells and their interaction could help refine the prognostic and predictive value of TILs in HR-positive breast cancer, and young patients may benefit from further immune biomarker development to potentially improve risk stratification and tailoring of treatment strategy. Please remember the results related to the PD-L1 that were very strongly associated with survival. So these are, of course, the acknowledgement of the group. Let me just underline in a couple of minutes some limitations, some further limitations of the study I found out. Of course, there were no association with other genomic prognostic biomarkers, PI3K and MAP kinase. This was probably due to the retrospective nature of the study, but it will be very important if you are going to trying to capture a new prognostic biomarker, to put the biomarker in comparison with other biomarkers which are being already demonstrated to be prognostic. They decided to use immunofluorescence instead of multiplex immunohistochemistry, or in situ transcriptomic, that is a new technology which allows to evaluate, virtually the whole transcriptome within a single section. There was no interaction with the TILs by hematoxylin and eosin, which have been evaluated in the past, or the mutational tumor burden, and as I showed before, the study was underpowered for capture a signal in ER positive within the adjuvant setting, because of course you need probably more event. This is because, as the author properly mentioned, the interplay between the tumor and the tumor microenvironment is very complex. So if you are willing to capture this kind of interplay, you should rather get to more complex and omic approach, as you see here with the single cell transcriptomic that we just set in our department. And let me underline that, of course, if you are willing to evaluate the interplay between cancer and lymphocytes, you have a couple of different tools. Of course, there is the tumor mutational burden, the TILs by the hematoxin and deoxin, immunohistochemistry for PD-L1, that is the only validated biomarker for immunotherapy, and gene expression analysis. I will remember that there is, the TILs, they have been very, properly and robustly specified in the past. This is just what you can do by immunohistochemistry, just evaluating the TILs. And we know very well, and this could help you in one of the question. We know from the past that the TILs, they are higher in basal-like triple negative, then in HER2, then in luminal B, then in luminal A. So they are associated with the tumor mutational burden, as you see here in comparison with TILs. And also it is very important to underline the fact that we should rather evaluate the expression of PD-L1 by HND. And lastly, let me underline that the others, they selected a population of HR positive tumors, but we know from the guidelines that from the ASCO CAP guidelines that a positive tumor, ER positive tumor, is a tumor with more than 1% of neoplastic cells, but it has been very well demonstrated that tumor up to 10% of ER positive cells, which were probably included within this study, they have a different behavior. They basically behave as a triple negative breast cancer. So it will be very important for these authors to properly select a population of patients within their own population with more than 10% of ER positive tumors, because according to the new guidelines, tumors with less than 10% of ER positive cells, they should be scored as ER low breast cancer, and we know that they have a different and poorer survival than the other subtype. Okay, this is my last slide. Sorry if I was a bit late, and thank you very much for your kind attention.
Grazie mille, Giancarlo. Thank you very much.
Grazie.
So now we will have the revoting process. And the questions are the same. So we're interested which kind of results we'll have after your beautiful presentation. So the first question, what TILs are. The second question, what's the type of breast cancer associated with high level of TILs? And the third one, which of the following statement is false? Okay. So what we have now, we'll see after a couple of, oh yes. So we have the 85% of true answer.
Yes, sure. We are very happy about that. In fact, TILs are prognostic and predictive marker.
Super.
They are high level is associated with improved survival. This is fantastic.
The second results of second question. Oh, heterogeneity.
Yes, so the second question was related to the subtype. No, it was related to the subtype. But I'm quite happy because, of course, the subtype that is associated with a higher level is the D subtype, so the basal light. But this is Irakli, this is
Yes.
truly the more or less the percentage of patients with the different subtypes having a high content of T. So the answer is quite fine for me.
Okay, thank you. And the results of the third question. Woo!
Yes, and yes, but I mean, let me tell you that the right answer is the second one, the high T helper and T regulatory cell expression associated with the reduced invasive breast cancer-free survival. Probably here there is the problem that in the question it was asked which statement was false and not true, so
yes.
it may be confusing. And let me also tell you, Irakli, that as I showed, the results related to the prognosis of the TILs in this study, it was quite complex to be understood. But at the end of the day, the message is that the higher the number of TILs and the better the survival, either in this setting.
Okay, and Giancarlo, also Dilara wants to comment on Russia to the audience.
Thank you.
Yes, thank you very much, dear Professor, for your presentation. I wanted to comment the answers of the audience, non-heterogenic answers. So the first one, what TILs mean, you explained more or less okay. So second question, which subtype of breast cancer is associated with high level of TILs? We speak about basal-like cancer. Dear audience, please memorize. The answer number 4 is correct. And the question number 3, the task was, which statement is false? Professor Pruneri explained us that the high expression of T helper and T regulatory cell expression is associated with reduced IBCFS and DDFS. So probably the audience did not understand the task correctly. So you should find the false statement. Means the first and the third are correct, but you should choose the second one, the false statement. So just we try to explain in both languages.
Thanks to Dilara. Dilara comments which of the statements were true and which of them were false. So thank you very, very much. If you would like to have some comment, Giancarlo, if you want.
Yeah, sure. Very, very quickly. Again, Irakli and Dilara, many thanks for having me in the Congress, and sorry for not being able to join you in person. But
we miss you. We miss you.
We miss you.
Yes, yes, I can understand because it's my feeling as well. Let me just underline the fact that we are needing new biomarkers in breast cancer, especially probably in HR positive breast cancer, because as you know, there are a couple of new drugs coming on age in this setting. So I would say that we desperately need biomarkers in this setting. For example, think about the CDK4/6 inhibitor treatment. That is a quite expensive treatment. Yes. We probably should try to refine the population to be evaluated with this biomarker, with this drug. Let me just tell you that TILs could be quite an important biomarker for immunotherapy in the future, but my message is my final message is that as we know from what is happening, for example, when a new drug is licensed by EMA or FDA, that every new drug is associated with a new biomarker. What is very important, as you know, I'm a pathologist, is to develop a very robust network of pathological labs which are able to assess the biomarker, because this is very important for the patients and for the good results with the new drug. We know that now we have the HER2 low population, we have the new endocrine therapy for the ESR1 mutated tumors. So what we have to do is, treat the patient appropriately by surgery, by new drugs, but also to characterize them better by using the new biomarker within the pathological labs. So this is my message for the audience. It is very important to work together, the physicians, the surgeons, and the pathologists, in order to get the best treatment to our patients.
Super. Thank you very much. Thank you.
Thank you. Thank you. Bye. Ciao.
Еще кто-то, может, есть какие-то комментарии?
Any other
Влад,
comments or questions?
Как у нас происходит в этом отношении развитие?
Would like to
Микрофончик дайте,
comment,
пожалуйста.
dear audience,
Положите на
anything
стуле.
into the microphone.
Добрый день всем.
Good day, everybody. Thank you very much, dear professor. Thank you very much for this opportunity to listen to this lecture. The tumor-infiltrated lymphocyte problem is so relevant now, not only for the breast cancer, but in each type of the cancer tumor. It is also related to the lymphoproliferative tumors and also regarding lung cancer and breast cancer everywhere. And Professor Giancarlo Pruneri's lecture is very interesting. It's different because the basis is a very different cohort of patients. This is hormone-positive HER2 negative patients. We are pathologists and clinicists. Very frequent we hear about TILs in triple-negative breast cancers, and I'm sure that basal subtype is also triple-negative breast cancer. And for me, it was extremely interesting to know from this presentation, because even in cohort there was BRCA1 and 2, and it gives us an idea there is a very long way ahead of us. And I completely agree, Professor Giancarlo, that there is a highly need in laboratories and pathologists. They should be aware about all the challenges in oncology that we see right now.
Спасибо, уважаемые коллеги.
Thank you, dear colleagues.
Дискуссия у нас закончилась, то у нас сейчас
if you have no more questions or comments, we thank the professor. And now we have the coffee break till 12:20. 20 minutes past 12, we are back, and the presidium will be headed by Nina Apollonovna.
Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. KazCS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов.
Құрметті қонақтар, ары қарай жалғастырамыз. Бізде
Dear ladies and gentlemen,
осы Kazakhstan Consensite несі бар, приложениесі бар,
we
iPhone-ға және
continue our
Samsung-ға
session.
App Store
Please
немесе
use
Play Market-тен
the
жүктеп
App
алсаңыздар болады
Store in
приложениені.
order to
Бұл жерде
download
барлығы
the
толық көрсетілген
application.
и барлығын қарауға болады. Программа барлығы
And
толық
there is an agenda over there.
Құрметті Чичуа Нино және Натия Джохадзе, сіздерді симпозиумға
Right
модераторлық
now
ету
we
үшін
have
подиумға
the
өтулеріңізді
chairs,
өтініп сұраймыз.
Professor Chichua and Professor Kohadze. So you can download the application
Всю подробную информацию вы
of
можете найти в
the
этом приложении и
Kazakh Cancer
скачать его.
Society. You can find
Сейчас мы
all the
приглашаем
information
наших
available
следующих
there.
модераторов
Now we
Чичуа Нино
kindly
и Натя
invite
Джохадзе.
dear moderators Miss Chichua and Miss Yohadze.
First of all, включу.
Говорите, говорите.
First of all, let me greet you and welcome you to our republic and wish you fruitful work at ASCO symposium. Today's section highlights the problem of drug therapy, the use of CDK4/6 inhibition with hormone therapy in patients with hormone-positive and HER2-negative forms of early breast cancer in the neoadjuvant and adjuvant periods, as well as the use of neoadjuvant chemotherapy of triple-negative breast cancer. Можно я по-русски скажу, что сегодняшние доклады
My today report will be relevant to neoadjuvant and adjuvant therapy of CDK with hormone therapy in patients with hormone positive and HER2 negative forms of breast cancer. There are different medications as a first line to treat the breast cancer, and now there will be researches made to apply those medications for patients in early stages of breast cancer in neoadjuvant and adjuvant therapy.
Good afternoon. We continue our second session of Best of ASCO. For those who joined us now, we had wonderful first session. So we proceed, and for the speech, we invite the first speaker, Carmine De Angelis, MD, PhD, medical oncologist at the oncology unit in Azienda Ospedaliera, University of Federico, to Italy. Thank you. The floor is yours.
Thank you. Thank you so much. Thank you, the moderator. Thank you, the scientific committee and the organizer of this event for inviting me today, discussing and showing you the data from this very important trial, a practice changes trial. So I'm honored to be here to present the data from the phase 3 NATALY trial, the trial of ribociclib plus endocrine therapy as the adjuvant treatment in patients with hormonal receptor positive, HER2 negative early breast cancer. I'm Carmine De Angelis from the University of Naples, Italy. I'm a medical oncologist, a physician scientist. I've been working for more than 20 years on breast cancer with a specific focus on the ER-positive breast cancer and CDK4/6 inhibitors. So just to give you a little bit of the background of the, to understand, to really understand the importance of this trial, is that we know that the breast cancer is the most common malignancy that is diagnosed and is the leading cause of mortality, cancer mortality in worldwide. and with more than 2 million of new cases globally. And
Carmen, sorry for interruption. We just need to go initially to the questions.
I'm so sorry. And, you also remember me before, and I completely forgot. So I'm sorry. So going back, first the questions. Okay. So I don't have the question here. So if you scan the Q. Okay, so the first question, I give you the time to scan the QR code. So the first question is, phase 3 NATALY trials include postmenopausal women with ER/HER2 negative advanced breast cancer and no prior treatment for that advanced disease, pre-perimenopausal women with hormone receptor positive HER2 negative advanced breast cancer. And the third answer is patient with stage 2 and 3 hormone receptor positive HER2 negative early breast cancer, including those with no nodal involvement and are at risk of disease recurrence up to decades after initial diagnosis. And then the second question is, which of the following statement is true regarding the duration of therapy with Kisqali plus endocrine therapy in the NATALY trial? And the third one is, which of the following statement is false? Adjuvant treatment helps to destroy macrometastasis. Risk of recurrence is one of the factors including guiding treatment decision in early breast cancer, and distant recurrence is not likely to occur in patients who have received standard of care adjuvant treatment. I don't know if we have already the results. Not? Okay, so this is the first question. First phase 3 NATALY trial includes patients with stage 2 and 3 hormone receptor positive. The C was the most common ones. At the end, we will see if this is the right one. So the second question is, which of the following statements is true regarding the duration of therapy with Kisqali? And we have pretty heterogeneous, so I should pay attention on this on this question. And the third one, okay, which of the following statement is false? And the majority choose the answer C, and then we'll check at the end if it's true or not. Okay, so I think now we can move. Again, I'm sorry to forgot, and the organizer remind me twice, but I completely forgot. Okay, so back to our presentation. We were talking about the background, and we were saying that the majority of breast cancer, fortunately, are diagnosed at the early stage, stage 1 and 4. Around 4 to 7% of new diagnoses are de novo metastatic disease. And the majority, around 70% of breast cancer, are the so-called luminal breast cancer. That means that express the estrogen, the hormonal receptor, majorly the estrogen receptor and progesterone receptor, and do not overexpress the HER2 transmembrane receptor. And for this kind of tumor, so the luminal early stage breast cancer, the intent of the treatment is to cure the patient, and the treatment is a multimodal treatment including surgery, radiation therapy, chemotherapy, and adjuvant endocrine therapy. That the time could be by 5 to 10 years according to the risk stratification of the patient. However, while these treatments are so effective, the patient, 1/3 of patients with stage 2 and around 50% of patients with stage 3 hormone receptor positive HER2 negative early breast cancer will experience a relapse of the recurrence of the disease. And this can happen for luminal breast cancer even decades after the initial diagnosis. So one of the clinical unmet needs is to try how we can try to improve patient outcome, long-term outcome in patients with early stage breast cancer. And we know that in the metastatic setting, the development and the introduction in clinical practice of the inhibitor of the CDK4 and 6, the in addition to endocrine therapy, markedly improve the long-term outcome, the progression-free survival, the response rate, the overall survival. And we have now 3 CDK4/6 inhibitors that are approved for the metastatic setting: palbociclib, ribociclib, abemaciclib. And among these 3, ribociclib is the one that have significantly improved both progression-free survival, overall survival, while maintaining or improving quality of life in patients with hormone receptor positive, HER2 negative, advanced breast cancer. And this was independent by the endocrine therapy partner, and independent by the menopausal status, independent by the endocrine sensitive or resistant disease. So based on this amazing data, the steering committee of the NATALY trial, I mean the people that thought about this trial, tried to see if the CDK4/6 inhibitor, and in this specific case the ribociclib, could improve the outcome of patients with early stage breast cancer. And we know also that in the last years we have 4 trials, 3 to 4 trials that test the CDK4/6 inhibitor in the adjuvant setting. And among these trials that we use both palbociclib and abemaciclib, only the one with abemaciclib, the monarchy trial, show positive results, but in a patient population at high risk. And when we can maybe discuss later this risk, especially patients with no positive tumors. So the NATALY trials, this is the study design of the trial, is a trial that enrolled more than 5,000 patients. And these patients with early stage luminal breast cancer were randomized 1-to-1 to receive standard endocrine therapy for at least 5 years. Where for standard endocrine therapy, we mean the non-steroidal aromatase inhibitor letrozole or anastrozole, plus goserelin, so the ovarian suppression in men on women in premenopausal status, or the experimental arm of the standard endocrine therapy plus ribociclib. The primary endpoint was the invasive disease-free survival using a STEEP criteria. And the secondary endpoint were the recurrence-free survival, distant disease-free survival, overall survival, patient-reported outcomes, safety and tolerability, and pharmacokinetics studies. This trial is the study design is pretty similar to the other trials in the adjuvant setting testing the CDK4/6 inhibitor, but have some unique features. For example, this trial includes a broad population of patients. So it includes, of course, patients with high risk, means patients with stage 3, so or with an important lymph node involvement, axillary lymph node involvement, but include also patients at lower risk, for example, patients in stage 2A or stage 2B with node-negative tumors. Second, the dose that was used in this trial was not the standard dose that is approved in the metastatic setting, that we know that is 600 milligram, but they used a lower dose, 400 milligram, and this was based on the study in the metastatic setting showing that patients who experience a dose reduction due, for example, to a diverse event per protocol as the Mona Lisa trial protocols. So they have similar outcome of patients with 600 milligrams. So this means that the drug can work also effectively at 400 milligrams, and maybe we can, with this dose, we can improve tolerability while maintaining efficacy. And the third point, very interesting from a biological point of view, is the duration of treatment. That is, was 3 years of duration. And this, the rationale for choosing 3 years of duration is because by extending the duration of treatment, we can prolong cell cycle arrest and drive more cells into the senescent status. And in the previous talk, we shown the senescent, how it is important to reduce the risk of recurrence. So just to show you again the eligible patient in the NATALY trial, this table shows clearly that the patient population is a broad population, and actually only the patient with T1 and 0 trial or and 0 tumors node-negative tumors or the micrometastatic tumor were excluded, and the T2N0 tumors, were included if they were grade 3 or grade 2 with high KICC7 or high genomic risk. A little bit about the statistical method. The study was powered at 85%, assuming an hazard ratio of 0.76 for one side alpha level control at 0.025. And were planned two interim analyses, efficacy analysis, one at 350 events and the other at 425 events, with the final analysis planned to take place when the study will register 500 events. And at the data cutoff of January 2023 for the secondary interim analysis were documented 426 invasive disease-free survival events. And the statistical comparison was made with a protocol defined stopping boundary of one side of p-value less than 0.128 for superior efficacy. So these are the baseline characteristics, and as you can see, the characteristics are pretty well balanced across the two treatment arms. And these, in terms of patient with menopausal status, a little bit more patient, 56% in both arms were in postmenopausal, while 44% were in premenopausal. The anatomical stage, you can see a large part of patients have a stage 3 disease, 60%, while only 20% was in stage 2A, that is the one at a lower risk of recurrence. Patient with a node-negative tumor N0 went around 30% of the patient included in the trial. And according to the treatment, we can see, this is very important, that the majority of patients, 88% in both treatment arms, receive prior adjuvant or neoadjuvant chemotherapy. In terms of patient disposition, this is also an important slide to understand also the maturity of this trial, because we can see that around 75% of patients were still on treatment, both with ribociclib plus endocrine therapy or endocrine therapy alone. And of these patients, around 20–23% discontinued the endocrine therapy. And the reason of discontinuation was only for a few cases due to adverse events. This is something that we need to think about and talk about, because it's very important also the adherence to the treatment. Also, if you look in patients who complete ribociclib, we can see that 20% of patients completed 3 years of ribociclib. So the trial, of course, is not fully mature, so we need also more data and more follow-up to completely appreciate the impact and the results of this trial. So this is the Kaplan-Meier curves of the primary endpoint, the invasive disease-free survival, and it's clearly showed that based on these results, the trial, the results met the criteria to demonstrate a statistical significant and clinical superior efficacy of the addition of ribociclib to standard endocrine therapy. If you want to look specifically in the number, we can see an absolute difference in terms of invasive disease-free survival at 3 years of 3.3%. That means a reduction of the risk of invasive disease, of developing invasive disease, by 25.2% by adding ribociclib to endocrine therapy. And we can see the hazard ratio of 0.75 with a p-value of 0.014. when we look into the specific pre-specified clinically relevant subgroup, we can see that the benefit of invasive disease-free survival due to the addition of ribociclib is consistent across all these specified subgroup. Of course, we need to take in account that the number of the events is not very high, so this means that the confidence of interval could be very wide, and actually we need more data, more events to fully appreciate and fully draw conclusion on the specific subgroup. But overall, you can see that in all the subgroup, using ribociclib, we saw also in stage 2 disease in patients with low KICC7, so patients that were not at high risk, but we can say the intermediate risk of recurrence benefit from the addition of a CDK4/6 inhibitor. So this is the Kaplan-Meier curve, the secondary endpoint of distant disease-free survival, and again we can see that there is a clear benefit. So first, the distant disease-free survival is defined as the time from the date of randomization to date of the first event of distant recurrences. So this is important, of any cause or secondary primary non-breast invasive cancer. And again, the result was significant. The ribociclib induced a benefit, an absolute benefit in distant disease-free survival of 2.2%, with a reduction of the risk of distant event of 26%. So an hazard ratio of 0.739, p-value 0.0017. These are the overall survival data, clearly not mature, but so I won't comment on this graph. Of course, you know, we are still it's too early to talk about overall survival, but you know, we know that additional follow-up is planned and is ongoing, so we'll have this data in the coming years. But a signal still, you know, is present, we see in favor of ribociclib. Now, I'm going to show you the data about the safety of the ribo. That was very interesting because of the dose of the drug that was chosen of 400 milligram. And we can see actually that the most frequent all-grade events were of course, linked to the neutropenia, but with a very low of absence rate of febrile neutropenia. We have an 80.3% of grade 3 of liver-related adverse event, mostly transaminitis. And it's important to see that there is this event lead to the discontinuation of treatment in a minority of patients. What is important to see if the QT interval prolongation, that is something that it were in the past in the clinical setting, and we can see that the grade 3 at more than equal or more than 3 QT prolongation at the ECG is very, very low. It's 0.2%. So this is something that can, you know, ensure us to using these drugs is very safe also in the early setting. And then when we compare this safety profile, you know, observed in the NATALY trial with the one that we have seen in the Mona Lisa trial, there is a pool analysis of the Mona Lisa trial, we can clearly see that there is an important reduction, a numerical reduction of the event, both the all grade and grade equal or more or equal to 3. And looking specifically into the QT prolongation, we can see that from the metastatic setting, I mean, to the Mona Lisa trial, to the NATALY trial, the rate is much from 1.2% to 0.2%. Of course, there are two different populations, metastatic setting, adjuvant setting, but I believe that we also learn how to identify patients that can be at risk of QTc prolongation, and the drug is very, very safe at 400 milligram dose. So we can see this beautiful reduction of the incidence. So in conclusion, the NATALY trial met its primary endpoint at the second interim analysis, efficacy analysis. demonstrating a statistically significant and clinically meaningful improvement in invasive disease-free survival with ribociclib plus standard endocrine therapy over standard endocrine therapy alone. The invasive disease-free survival benefit was consistent across all the key specified patient subgroups. The results from secondary endpoints such as the distant disease-free survival consistently favored ribociclib plus standard endocrine therapy versus endocrine therapy alone. And what is important, that its 3-year regimen of ribociclib at the 400 milligram starting dose in the adjuvant setting is well tolerated. So based on these results, the NATALY trials support the combination of ribociclib plus endocrine therapy as a new treatment of choice in a broad patient population with stage 2 or stage 3 hormonal receptor positive, HER2 negative early breast cancer at risk of recurrence, including patients with no negative disease. Thank you so much. So we can now check again. I hope that that was clear. So we'll see in a second if the question, the QR code. So okay, so the first question was the phase 3 NATALY trial includes. The second one is which of the following statement is true regarding the duration of therapy. And the third one is which of the statement is false. Okay, so the results. So phase 3 NATALY trials include C is the right answer, so patient with stage 2 and 3 luminal early breast cancer, including those with no nodal involvement that are at risk of disease up to decades after initial diagnosis. So very good. Second one is which of the following. Okay, so here we have some heterogeneity we need to comment. So the statement was about the duration, the biological aspect of the duration of the inhibition. So the right answer was the C. So the biological rationale is the longer duration of the inhibition with CDK4/6 inhibitor induce more cells into the senescence. So stop the cells in because the mechanism of action of this drug is to stop G1-2S phase, so they have more cells in G0, G1, they induce senescence and they reduce the risk of recurrence. So the third one, which of the following statement is false? Yes, that's correct. So the distant recurrences are not likely to occur in patients who have received standard of care. It's false because we know that, as I said before, 1/3 of patients with stage 2 and 1 in 2 patients with stage 3 have a recurrence of disease. Okay. Thank you.
Натя, вы прокомментируете тоже еще раз для закрепления результата? Почему-то второй вопрос.
Thank you, Carmen, for your wonderful presentation. I think possibly to the end of the session we will summarize everything and we'll have a chance for the question to the end.
Да, второй вопрос, видимо, не поняли.
So we invite for the second speech Dr. Kaldagul Smagulova, PhD, head of the Chemotherapy Day Hospital Department, Kazlor, Kazakhstan. Stage is yours. Thank you.
Good day, dear ladies and gentlemen.
My presentation concerns the use CDK4/6 inhibitor palbociclib in neoadjuvant therapy for early breast cancer, as well as in identifying biomarkers of non-response with its use. Colleagues, let's start an interactive survey. Начнем с интерактива.
So let us start with the interactive session. The first question.
Question of mechanism of action of palbociclib. Механизм действия palbociclib.
So here is the mechanism of action of palbociclib. The first question.
Ингибитор mTOR.
The first answer, mTOR inhibitor. Second one, inhibition of CDK4 and 6. The third answer, the activation of signal pathway PI3K, AKT, mTOR. The second question.
Combined with endocrine therapy is standard of hormone-positive, HER2-negative early breast cancer, hormone-positive, HER2-positive early breast cancer, and the hormone-positive, HER2-negative metastatic breast cancer. 3 ответа на вопрос. На сегодняшний день стандартом
комбинации
palbociclib и эндокринной терапии
there are 3 different options. What are the indications? The ER/PR positive, HER2 negative, and early breast cancer. Then the third question.
Is false regarding primary objective and secondary endpoint of NEAR study. The question about the NEAR study, that's what we're going to talk about now. Этот вопрос как раз касается
The third question is related to the study that we are going to discuss in the presentation. And by the end of my lecture, I hope we will get back to the question number 3. And in case you have questions or comments, then we can discuss by the end of my presentation.
So CDK4/6 inhibitors and the endocrine therapy are standard of care in the treatment of estrogen receptor positive, HER2-negative advanced breast cancer. However, not all patients benefit equally from this treatment. NEAR was a phase 2 single-arm trial evaluating 4 months of neoadjuvant palbociclib and endocrine therapy in pre- or post-menopausal women with estrogen receptor positive, HER2-negative early breast cancer. The study was conducted at the Institut Julie Bordeaux and the University Libre de Bruxelles, Brussels, Belgium. The primary objective was to identify biomarkers of response by locally assisted ultrasound using RNA sequence on baseline pretreatment tumor biopsies. No response to treatment was defined as stable or progressive disease, CD or PD, at post-treatment ultrasound based on WHO criteria. Secondary endpoints included residual cancer body tumors, RCV3, and the absence of complete cell cycle arrest, defined as Ki-67 by immunohistochemistry less than 2.7% at surgery. Baseline clinical characteristic RNA sequence derived PAM50 subtypes and the mRNA expression of select ECRI1, Ki-67, CCNA1, RAB1, and the CDK6 genes were associated according to the ultrasound and the complete cell cycle arrest. Response also performed gene set enrichment analysis for 50 gene sets associated with cancer trails according to ultrasound and the complete cell cycle arrest. You can see on the slide study design, registration patients, patient screening, eligibility, assessment within 7 days, then inclusion primary ultrasound, collection of plasma, whole blood, and the biopsy samples also within 7 days. Biopsy was frozen and the formalin fixed paraffin embedded, followed by 2 treatment period. Treatment consisted of endocrine therapy in combination with palbociclib for 3 weeks at 125 milligrams daily, 1 week off. Ultrasound after treatment, then from 3 to 7 days, extended treatment period, then surgery, and on the day of surgery. Then surgery. And on the day of surgery, collection of plasma again, and the biopsy samples also frozen and the formalin fixed paraffin embedded. Then after 1 month, plasma sampling. Patient flow chart and baseline characteristics. 100 patients enrolled. Enrollment ended in September 2019. 3 patients did not meet inclusion criteria. 97 patients were eligible for evaluation, of which 24 patients had a cellularity for frozen biopsy, specimen less than 25%. Those 73 of 100 patients included in the study had initially frozen tumors with sufficient cellularity and a successful RNA sequence. Among 73 patients, 70% was postmenopausal women, 84% had tumors with a tumor 2, and 70% with nodulus 0. 75% had invasive ductal carcinoma, and 66% had tumors of the second histological grade. PAM50 subtypes obtained by RNA sequence were luminal A, luminal B, and non-luminal in 56 and 36 and 18% of patients respectively. Treatment response and the predictive biomarkers when evaluating the effect of treatment according to ultrasound among 73 patients, 31, this is 42%, had no response, of which 28 patients had stabilization of disease and 3 patients had progression of the disease. 23 patients, this is 31%, had a residual tumor RCV3. 53 of 73 patients had immunohistochemistry determined Ki67 available at the time of surgery, of which 14 patients, this is 26%, did not have complete cell cycle arrest. Interestingly, investigators accept high baseline CDK6 expression in patients with no response to ultrasound and or in patients with an complete cell cycle arrest. The researchers found an increase in the inflammatory response to interferon gamma gene, as well as an increase in the set of G2M checkpoint genes associated with proliferation in patients with ultrasound response. In patients without complete cell cycle arrest, the signaling pathway was not enrichment. So, NASI baseline clinical pathological characteristic, non-PAM50 subtypes, no expression of ACRI, Ki67, CCNI, and RIB1 were associated with non-response to ultrasound or absence complete cell cycle. So, conclusion, neoadjuvant palbociclib plus endocrine therapy was associated with a low rate of pathological complete response, only 1%, only 1 patient, but with effective proliferation shutdown, cell cycle arrest 74%. Responders to treatment had enriched in immunoactivation, high proliferation, and lower estrogen receptor signaling at baseline. Observed enrichment in the inflammatory response, interferon gamma gene response, and the G2M checkpoint gen 6 in patients with ultrasound response. Conversely, observed an enrichment of the early estrogen response gene set in patients with absence of ultrasound response. High pretreatment mRNA expression of the CDK6 gene was associated with absence of UZ ultrasound response or absence of complete cell cycle arrest in patients treated with neoadjuvant palbociclib and endocrine therapy. Independent validation is needed. Investigated this with to thanks all patients in the near study and the families. Thanks investigators, Institute Julia Bardot, Brussels, the clinical trial support of the Institute Julia Bardot and the Pfizer for the financial support in this academic study. I'm finished. Thank you very much for your attention. No back.
Probably first we will make an interactive session and then we will discuss Q&A.
Помогите не на полу, нажать кнопочку.
Please help us technically to push the button. The first question. Seems to me the first two questions were very easy for clinical oncologists. Let us check the answers first. But what about answers? Not all of them are correct. So the first question, what is the mechanism of action of palbociclib? 100% correct answers. Thank you very much. Now I'm okay with that. So the question was easy. So the second was easy as well. So question number 3. So the task was, this is the second phase of the study, that's why it was probably difficult. What is the application of palbociclib in neoadjuvant regimen? So the task was to choose the false statement. 50% of audience answered correctly. So the reduce of circulating tumor DNA at the end of the 4th cycle treatment. This is the false treatment. Means the answer C, the third answer. Please take your time and take the whole message. What is the false statement? So first you make the ultrasound and then RNA sequencing. And the residual cancer burden, I mentioned, they are the points to determine with immune histochemistry. So this is relevant neo-REA study. And the third statement is not relevant, is false. There was no task in the study like that to determine in the third line of treatment to determine DNA circulating tumor in a big university. 100 patients included. This is the second phase of study. Those who got palbociclib in neoadjuvant mode, they did not show response with ultrasound. Mainly, they showed the stabilization and progressing. But when we started to research with sequencing with a frozen biopsy, in Kazakhstan, we don't use a frozen biopsy In Kazakhstan, we don't use a frozen biopsy very frequently. Mainly, we use the formalin-fixed stabilized biopsy. So in this case, there was frozen biopsy used in order to determine the arrest of the cycle. That was 74%. Those who got neoadjuvant therapy, that was the second phase of the study, and then we would recommend a conventional therapy as in neoadjuvant therapy. Probably it will be radiotherapy or chemotherapy, and in the future, in the next study, when we get the final results, probably the standards would be changed. This is the way I think. I don't think it depends on hormone therapy, because in neoadjuvant, if hormone therapy would not help, why it would help in adjuvant therapy? Recently, we discussed the task was to determine the non-efficiency of application of CDK and together with ribociclib. Probably it would help in neoadjuvant mode. Kaldegul Kabakovna, I have a question. What is your opinion? What about efficiency CDK4 and 6 in neoadjuvant therapy? Would it be a standard? And the question to the previous one, which patients will be prescribed to have CDK4 and 6? What is the opinion of the practicing doctor? Thank you very much, Oksana Vladimirovna. Within the frames of this study, there was expression of CDK6 for those patients who did not show the response for this therapy. They had high expression of CDK6. Most probable it will be studied next, and when there will be a third phase, it will be for majority of patients. So 100 patients, 3 of them was out, not eligible, and there was a frozen biopsy sampled. I think the quantity is not enough. And in case we would get the quantitative results from the patients, probably then we would use the CDK in neoadjuvant mode. Like Professor Carman showed, in neoadjuvant mode, still there is no median of survival. This study is continued. So I believe we will use still CDK inhibitors.
I can answer from my side also. I think we need much more data about neoadjuvant chemotherapy, neoadjuvant CDK4/6 inhibitors, because really these data are not enough. Even in adjuvant setting, we have a lot of questions because yes, it's wonderful that we have additional drugs for the adjuvant endocrine therapy, but still there is a big challenge for the world, is that availability of drug is a big challenge, and the world is not the same and uniform, and availability of drugs is not the same around the world. And for the countries with poor healthcare systems, it's really very challenging to prescribe even adjuvant CDK4s, I think. Do you have in Kazakhstan, do you have abemaciclib currently used in adjuvant setting? No. So this is a problem. And really, if we look on the data, for example, in Natalie trial, 3.3% benefit. This is really very good, but if we count this in money, in order to get IDFS benefit in one patient, we need to treat 30 patients. And if we count it in money and we count it on the 3 years of treatment, this means we need millions of dollars for one IDFS beneficial event. So this has a huge expenses. For the future, my perspective and my hope is that possibly we will find some issues in selection of patients to check and to select those 1 or 2 or 3 in future patients who will be responding to this treatment in order to avoid a lot of other expenses and target this money to the other fields. So this is my question.
Thank you, Nadia.
Thank you.
Thank you, Nadia, and I agree with Nadia because of 1% we cannot spend huge money. Of course, we will adopt selectively whom to prescribe in neoadjuvant therapy, for instance, for those in high-risk groups. Any other comments, dear colleagues from Israel? Good day. I would like to add regarding the question on patients who did not show the response on neoadjuvant therapy, CDK4 and 6. I believe it's a very interesting question. At least one inhibitor would be included into the setting. It will be a problem to solve. Should it be the first-line regimen, especially for those who are showing metastatic progression, and for those who are in a trial who demonstrated that patients who are progressing in first line for those who are progressing with ribociclib, who are still showing small but still improve in survival when we combined endocrine therapy and CDK4 and 6 inhibitors. What are we limited with is with the precision of biomarking assessment. Like Natalie mentioned, they would react and their benefit would be maximum. Regarding Natalie's study, for me, this clinical study as an additional proof that CDK4 and 6 work in the early stage and monoreceptor positive and HER2 negative, and we need to monitor for longer time because monoERIC trial on treatment effect, the first results after the first 2 years of treatment, the difference would be more in the long-term treatment. So post-treatment effect on CDK4 and 6 should be much more considerable and significant instead of on treatment. This is my point of view. Thank you. Any other questions? Thank you very much, Koldigul Kabakovna. Very useful information for clinical oncologists, and there is a very active discussion after your presentation. My question is regarding the methods of assessment on the residual cell cycle. If I understand correctly, this is immune histochemistry. As far as I know, we don't have this methodology available here in Kazakhstan. So patients who got target therapy on CDK4 and 6, so this method is made afterwards, means we should get the second time biopsy from the focal point, and then we should make the liquid biopsy. We assessed the arrest of the cell cycle with the Ki-67 with immune histochemistry, and before surgery there was frozen biopsy made and in formalin, and after surgery we checked the percentage of Ki-67. If Ki-67 was more than 2.7%, means in such patients they are in group with no response. and then it was reconfirmed with a cell cycle arrest. In case it was less, then they were included into the group of patients who with a response. So in this study, 74% of patients showed the cell cycle arrest. And I'm not sure if there will be a liquid biopsy available. So KI-67, this is immune histochemistry analysis. Elvira Bulatovna, please comment. I believe that the results and methods mentioned by Kaldegul, this is immune histochemistry, this is the substitution marker. You can assess what is the phase of the cell cycle for the tumor. And for sure, we may say that most probable it will be available as a method using the circulating method, but still not available here. So liquid biopsy is not routine method here yet. Yes, it's not a standard method. Yes, it can be an experimental method, PCF. But what are the criteria? What is the sensitivity of KI-67? Probably there is another one method available to determine. Probably it will be something, because right now it is just an immune histochemistry method available. There is another question to Kaldegul Kabakovna. Please tell us, the cell cycle arrest, does it provide the increase of non-relapse period? Is it significant like PCI? The mechanism of CDK4/6 inhibitors, this is the cell cycle arrest. So I believe yes. So the majority of target medications are giving cell cycle arrest, and they provide stabilization of the process and increase of apoptosis. Yes, there is a correlation and interdependence, because the interaction of medication is the cell cycle. Thank you very much for the interesting discussion.
Thank you. Thank you very much for your presentation. It was really hot discussion here.
The next speaker is our guest, distinguished guest from Tbilisi, Nadia Jokhadze, MD, Chief of Clinical Oncology Department, American Hospital in Tbilisi, Georgia.
First of all, I would like to thank Dilara Radikovna for the invitation and all the organizing committee also. It's my great pleasure to present today the newest data from ASCO 2023 about efficacy and safety results by age in monarchy, a study of adjuvant abemaciclib combined with endocrine therapy in patients with hormone receptor positive, HER2 negative, node positive, high-risk early breast cancer. But before we proceed with presentation, I would like to ask you again to start our evaluation, pre-evaluation questionnaires. So you have QR codes on your screens, please scan. And again, we have 3 questions. What we know about monarchy study till now. The question 1 is, monarchy was designed to evaluate the addition of 2 years of adjuvant abemaciclib to endocrine therapy in hormone receptor positive, HER2 negative, node positive, high-risk early breast cancer. The second question is, monarchy was designed to evaluate the addition of 1 year of adjuvant abemaciclib with the same study. I'm sorry, we cannot parallelly see what are you looking for on the screen, so that's why possibly we are in a hurry. And the third question is, monarchy was designed to evaluate the efficacy and safety of abemaciclib in combination with fulvestrant, comparing to fulvestrant alone in hormone receptor positive, HER2 negative advanced breast cancer. This is for the first question, answers. Done? Okay. The second question is, which of the following factors implies to high-risk early breast cancer? First, the residual. This is, okay. For the first question, we already have the answers. Yeah, 30% think that it was evaluated for the addition of 2 years of adjuvant abemaciclib. No one thinks that it was designed to evaluate the addition of 1 year, and some which the, okay, no? You did the second? Tretий question, okay. Adjuvant abemaciclib, the third question is, adjuvant abemaciclib plus endocrine therapy showed consistent treatment benefit across the age groups. We asked the false question. Both across the subgroups, which clinically meaningful absolute risk reduction in IDFS and distant recurrent-free survival rates observed in both younger and older patients. The second answer is, across all patients treated with abemaciclib, IDFS outcomes were reduced to those who underwent those modifications compared to those who did not. And the third answer is, quality of life was preserved in both age groups during 2-year treatment period. Again, we ask about the false question. Yeah, we have 60% for the answer C. Let's see what will be to the end. Okay. Okay, as a background, I will say that patients with node-positive early breast cancer are at high risk of recurrence, up to 30% at 5 years, and need intensification of treatment. Monarchy was designed to evaluate the addition of 2 years of adjuvant abemaciclib to endocrine therapy in hormone receptor positive, HER2 negative, node-positive, high-risk early breast cancer. Abemaciclib is globally approved standard of adjuvant treatment for node-positive, high-risk early breast cancer and has received NCCN Category 1 rating in this setting. A goal of optimal adjuvant therapy is to eradicate micrometastatic disease within an achievable treatment period in order to maximize the treatment compliance, especially in adjuvant setting where we know this is a problem. Abemaciclib induces a potent and sustained apoptotic effect and is dosed continuously, in contrast with other CDK4/6 inhibitors that are administered intermittently and induce senescence. Regarding Kaplan-Meier's, both IDFS and invasive disease-free survival and distant recurrent-free survival benefit persists and even deepens beyond completion of 2 years of abemaciclib treatment period. On the left, we see the invasive disease-free survival. Initially, at the first look of data within 24 months follow-up, it was the absolute benefit, 2.8%. At 3 years, the curve widens to the 4.8%, and ultimately at 4 years now, magnitude of benefit is 6.4%, representing total 38% reduction in risk of developing invasive image. Similarly, on the right, in terms of distant recurrent-free survival, at 2 years of follow-up, the benefit was 2.5%. At 3 years, it increased to 4.1%, and at 4 years now, it is 5.9%, again representing 34% reduction in risk of developing distant recurrent events. The quality of life measured by FACT-B score was preserved in adjuvant abemaciclib across all this treatment, 24 months treatment period. Older patients often have higher burden of comorbidities and may be at increased risk of toxicities from Kirsten treatment that we provide. Older patients are also frequently underrepresented in clinical trials, we know this, and the aim of this study and objective was to explore the efficacy and safety of adjuvant abemaciclib in a subgroup of older patients enrolled in Monarchy study. We will see in this study design, but again, over 5,600 patients with hormone receptor positive, high risk, early breast cancer were randomized to receive 2 years of endocrine therapy alone or 2 years of endocrine therapy in combination with abemaciclib. All patients went on to receive the 3 to 8 years of standard single agent endocrine therapy per patient and doctor's decision. All patients are off abemaciclib now, and with a median follow-up of 42 months. Efficacy, safety, and patient-reported outcomes were conducted in 2 age groups, those who were under 65 years of age and those who were over 65 years of age. Patients that were greater than 75 years of age made just 3% of the study population, which really precluded a detailed outcome analysis in this subgroup. Hazard ratios were estimated using a stratified Cox proportional hazard model within each subgroup. So older patients initially had more comorbidities, a higher ECOG performance statuses, and received less prior adjuvant and neoadjuvant chemotherapy. Specifically, in terms of prior adjuvant and neoadjuvant chemotherapy, 97% of those who were less than 65 years old had received chemotherapy, where the only 82% of those who were over 65 had chemo. Similarly, in terms of comorbidities, from the patient that had 4 or more baseline existing comorbidities, only 33 were young, while others were older. Actually, the older patients in this study derived the similar abemaciclib benefit to the intention to treat population, and I call your attention to the bottom of this. In terms of 4-year rate in patients younger than 65, the endocrine therapy alone compared to those who received endocrine therapy plus abemaciclib, invasive disease-free survival was improved from 79.4% up to 86.5% with an absolute magnitude of benefit 6.7%. Similarly, in the patients who were 65 years and older, IDPS was improved from 76.8% to 82% with 5.7% magnitude of benefit. And these numbers were not different. In terms of distant recurrent-free survival, a very similar story. An absolute magnitude of benefit, 6.2% for the younger patients and 4.6% in patients that were 65 years of age and greater. And consistent results were seen in cohort 1 also. Adverse event rates were also similar between age groups. In terms of neutropenia, LT increase, venous thromboembolism, ILD, there were not even numerical increases in adverse events for the older patients compared to the younger ones. In terms of diarrhea, any grade diarrhea was actually less than 5% in older patients, but less common in older patients than in youngers. However, grade 3 and more severe diarrhea was 5% more frequent in elderly patients. Similarly, grade 3 fatigue occurred in 2% of younger patients and 6% of older patients, which is also higher in the older group. Despite appropriate tolerability, dose adjustments were common in older patients. If in young patients, just 42% underwent dose reductions, in patients that were more than 65 years of age, 55% were dose reduced. Similarly, discontinuations were also more than double in older patients. 50% in a group that was younger than 65, and 38% in those who were over 65. And I'd like particularly highlight the last row. Over a half of patients that discontinued treatment did so without attempting dose reduction. And this happened across both age groups, and this is really a big problem. To examine whether the dose reductions impaired efficacy or whether the abemaciclib benefit was maintained when this was happening for the managing adverse events, relative dose intensity analysis was performed. To explore the impact of dose adjustments on abemaciclib efficacy, patients treated with abemaciclib were classified into three equal categories to the relative dose intensity. The red bar represents the 93% of intended dose intensity or above, blue 66 to 93, and gray 0.0 to 66%. Invasive disease-free survival rates were estimated within each subgroup, and the 4-year invasive disease-free survival rates were consistent. 87% in the lower relative dose intensity group and 83.7% in the highest. Similar findings were observed in the patient treated with abemaciclib in cohort 1. And again, the quality of life was similar between arms, where abemaciclib is indicated in red and endocrine therapy alone is indicated in blue, as well as across age subgroups, where the bolder darker line are those with patients who were older, and the more faint lines are those who were less than 65. In conclusion, based on this, I would, and actually the investigators, suggest that in older patients, in order to maintain the treatment compliance, particularly seeing that over half of patients that discontinued abemaciclib did so without attempting dose reduction, the quality of life was preserved in both age groups during the 2-year treatment period, and this data support the use of adjuvant abemaciclib across age groups and can be used to counsel patients about expectations of treatment experience and also the safety and utilizing dose reductions if needed. Authors of this study thanks more than 5,000 patient volunteers and their families and caregivers from 603 sites and 38 countries for participating in this trial, as well as investigators and support staff and trial members who participated in this wonderful work. Thank you very much for your attention.
Натя, спасибо.
So, now, let's recheck ourselves again. Again, QR codes, what we see. The first question. Why it's changed. The initial answers were correct. Okay. Actually, the monarchy study was designed to evaluate the addition of 2 years of adjuvant abemaciclib to endocrine therapy in hormone receptor positive, HER2 negative, node positive, high-risk breast cancer. So 2 additional years. This is a correct answer. For the second question, which of the following factors implies to high-risk early breast cancer? Yes, the most participants.
Наличие резидуальной болезни, да? Возможности. Но у нас есть 42%, которые этого не знают.
Yeah. The correct answer is the residual cancer burden greater than 3, young age, and low cell proliferation, just 3, implies to high-risk early breast cancer. This is the correct answer. And the third question, which of the following statements is false? Yeah, that's correct. 58% of attendees answered correct. So the answer was across all patients treated with abemaciclib, IDFS outcomes were reduced in those who underwent dose reductions compared to those who did not. Actually, no, it was not. It was the same. So we can. It is very important not to omit the treatment. It is very important to stay consistent with treatment. We always have the possibility to dose reduce and we still maintain the effect of the treatment. So this is important message. Thank you very much. If you have any questions or otherwise we will also come back to the questions and we will summarize the session. So if you don't.
Thank you.
Next speaker. The next speaker. The next speaker is Rita Toker, MD, Senior Oncologist, Sakura University Medical Center, Israel. Please, Rita, welcome to the... Is Rita with us?
Рита. Вот. Спикер готов.
Welcome to the stage.
Thank you very much. Thank you very much for inviting me. And it's my great pleasure to be here and a great opportunity to discuss an optimal treatment for early stage triple negative breast cancer. I'll proceed in Russian. I was asked to give my lecture in Russian, so it will be my pleasure to try to talk about early stage triple negative breast cancer in Russian. And I'll start with 3 questions. The first question is, do you consider adjuvant use of checkpoint inhibitors after surgery if we reach pathological complete response as a result of neoadjuvant immunochemotherapy for early-stage triple-negative breast cancer? Yes, enough data on the feasibility of such an approach. No, the difference in disease-free and overall survival is not significant. Yes, for certain category of patients. Not enough research data for a definitive answer. And the second question is, what would you prefer for neoadjuvant therapy for early-stage triple-negative breast cancer? Atezolizumab, second option, pembrolizumab, third option, durvalumab, and the fourth option, none of above. And the third and last, the main factors and the decision to prescribe, refuse to conduct adjuvant immunotherapy for early-stage triple-negative breast cancer is: first option, patient's age; second, a PCR rate; third, number of affected involved lymph nodes, and all answers are correct. So I'll start with my lecture and я могу начать? We are waiting for response. So is this the result of first question or third question? PCR rate is the first question, and the most of audience said that third option is correct. Yes, for a certain category of patients. And the second one? Pembrolizumab is the preferred option and it is the right answer, excuse me. And the third one, the main factors are and again, you know everything. So thank you very much. And I'll try to discuss an issue of treatment option for early stage triple negative breast cancer. Итак, трипл-негативный рак груди
So
считается одним из наиболее агрессивных
breast
типов
cancer
опухолей
is
груди.
considered one of the
Он
most challenging breast
характеризуется
cancer
довольно высокой
subtype to
степенью
treat,
пролиферации,
which
и тем
is
самым,
very
даже когда диагностируется
proliferant.
в относительно
So
ранней
when
стадии
it
болезни,
is
а большинство
even
пациентов
diagnosed at early
диагностируется в ранней
stages,
стадии
which is
болезни,
true for
по-прежнему большая
most of
часть
the
пациентов с
patients,
трипл-негативным раком диагностируется в более продвинутых
this
стадиях по сравнению с другими
triple-negative
подтипами.
are at more
До
advanced
настоящего
stages,
времени
initial
наша возможность
diagnosed.
повлиять на
And
исход
until
трипл-негативной даже в
now,
ранней стадии рака груди была очень ограничена
our
и главным образом
opportunity
ограничивалась
to
полихимиотерапией,
impact
которую мы давали
usually
в различных
to treat
комбинациях.
usually limited by
Трипл-негативный
polychemotherapy in
рак
various
молочной железы
combinations.
характеризуется
Triple-negative
полным
cancer is
отсутствием
characterized absolute
наличия
lack
проявления
of
экспрессии
any
рецепторов
expressions
эстроген-прогестерон и
HR
HER2.
or
В среднем частота диагностики ранней стадии трипл-негативного рака груди составляет порядка 15-20%. В Израиле только 10% пациентов, диагностированных с раком груди, обнаруживается у них трипл-негативная форма рака груди.
Breast
На сегодняшний
cancer.
день большинство пациентов,
As of
которые
today,
диагностируются
most
со второй
of
и
the
третьей
patients
стадии
which are
рака
diagnosed
молочной
with
железы
first and
трипл-негативным
second
подвидом, они
triple-negative
являются
stage of
кандидатами
cancer are
для назначения
candidates
неоадъювантного
for
лечения.
neoadjuvant
И на сегодняшний
therapy.
день мы
And
вполне четко
until
представляем,
now,
даем
we
отчет, для чего мы
realized for
назначаем
what
неоадъювантное
we
лечение. Во-первых,
prescribe this
уменьшить количество
therapy. First of
существующей
all,
болезни и тем
decrease
самым позволить
primary
нашим
tumor
хирургам
size and
провести,
help our
так сказать,
surgeons
орган-сохраняющую
to
операцию, то есть
make
частичное удаление груди
organ-saving
вместо полного
operations
удаления груди
instead
мастектомии. Кроме
of
того,
total
неоадъювантное лечение
mastectomy.
позволяет нам на
And
очень
in
ранних
addition,
стадиях четко
the
определить эффективность избранного лечения.
treatment give us
И
assessment of
в
efficacy
сегодняшний
of our initial
день
treatment.
неоадъювантное лечение
And currently, neoadjuvant treatment and assessment of its efficiency enables us to customize the adjuvant treatment according to the response of the patient. Depends which way she responded on the neoadjuvant therapy. One of the methods to evaluate response to neoadjuvant therapy is pathological complete response, means the presence or absence of residual disease after NAC. Why the pathological complete response is a substitution? Because from one side it determines the sensitivity, and from another side it understands the aggressive tumors like triple negative breast cancers. This is a direct correlation to the remote forecast, and we know for the patient their overall survival is better comparing to the patients who did not reach that level. To my point of view, the most important assessment of neoadjuvant therapy is RCB, the residual cancer burden, because this way we can determine quantitatively the way tumor reacted and responded, because all subtypes of breast cancer shows correlation. Less of tumor, better forecast is. Besides the PCR, the minimum residue determines the favorable forecast, including the overall survival rate. So for many years we give the chemotherapy, but still we ask ourselves, what is the optimum level of chemotherapy for neoadjuvant therapy for triple negative breast cancer? Anthracyclines are standard component of any neoadjuvant treatment. So what is the optimum scheme regimen? One of studies, CLGB 9741, we call it Alliance trial, studied different regimens of anthracycline doxams combined with toxins. And there is a comparative analysis on efficiency, anthracycline once in 3 weeks prescribable. And in order to assess those once in 3 weeks, their forecast was much better. There was a decrease of the relapse and improve of the overall survival. If we check one of the biggest meta-analyses, we see that patients with chemotherapy once in 2 weeks, comparing to those once in 3 weeks, in the dense chemotherapy, the relapse was much less, and the mortality because of breast cancer decreased in patients who got the neoadjuvant dense dose therapy. Regarding toxins, we do not discuss anthracyclines. We discuss the optimum regimen. This is one of the large-scale meta-analysis showing petrotaxel weekly or 175 milliliters per square meter once in 2 weeks is most efficient, instead of 175 milligram per square meter in 3 weeks. It could be Taxol, 2 weeks. This is a standard approach to the neoadjuvant therapy for early stage patients. The question discussed during 20 years, to give or not to give the platinum-containing therapy. There were many studies performed, and for a long time there was no one and single response. There are 3 results: GALGB, GPR60, and brightness. Different responses, different results, but in each of them there was an exact question: to give or not to give platinum-containing therapy, in addition to the conventional therapy. And here you may see that in all the studies there is an improvement to reach the non-pathological response, instead of 40% who did not get the platinum-containing therapy. In second study, GPR60, it showed the decrease of relapse, but there is no increase of overall survival. And the tendency to the disease-free and overall survival in brightness study is shown, but still the results are different. So to do or not to do, still discussable. And here is the phase 3 of the research. The younger women are getting more benefit from carboplatinum, and there was the phase 3, more than 700 patients, younger patients, younger than 50 years old, and patients from the high-risk group, and there was a stratification of women elder and younger than 50 years old, and premenopause and postmenopause. So there was standard types of chemotherapy prescribed, and there was event-free survival assessment, so without any events. And second group with a complete response. So here is the result. It explains itself. We see in patients younger than 50, there is a high percentage of patients who reached a complete pathological response, comparing to those patients who are elder than 50 years old. And there is 2 additional cofactors, and event-free survival without disease were much better in that group who are younger than 50 years old. And here we may see that patients who got platinum in combination with a standard chemotherapy, the 5 years survival was 75%, comparing to 65% in control group. Comparing to the control group, where survival was only 66%. So, to say yes or no to carboplatinum, we may say yes to the patients with a higher risk, to the higher grade and relapse, and to those who are younger than 50 years old. Despite the facts are different, there is another stage of discussion. Yes or no to immune chemotherapy? Which way to combine immune therapy with available chemotherapy? Here is the design of main clinical trials to understand the comparison of monotherapy and combined therapy. And in only 2 researches, immune therapy was provided in adjuvant and neoadjuvant settings. In other 2 researches, there were other inhibitors, and they were provided in neoadjuvant therapy only. The study called GEPARD-NUEVA, only 175 patients with the triple-negative breast cancer got chemotherapy together with durvalumab. And we may see that durvalumab in neoadjuvant settings increased the complete response. Secondly, decreased the possibility of relapse. And thirdly, we see that when we use a pathological complete response as an assessment of efficiency and prognostic factor, the patients who got the complete pathological response, their forecast is much better than in those patients who did not reach complete pathological response. Does not depend on the immune therapy availability. Another study, Keynote 522, it changes our understanding the treatment of the early stages triple-negative breast cancer. This is the 3rd phase of the study. The patients with the triple-negative study were randomized into groups. One got standard chemotherapy, including the paclitaxel with chemotherapy weekly or once in 3 weeks, then 4 weeks of combinations, tetracycline once in 3 weeks. In order to prescribe it once in 3 weeks, 200 milligrams once in 3 weeks, then chemotherapy, and then group of placebo. Those who got chemotherapy, they got surgery, and it was specific for this study. The patients with pembrolizumab continued the treatment with pembrolizumab, and those who got chemotherapy, they continued with placebo. So 25 patients with 3rd stage. What are the lessons learned? Let me remind you that one of the main lessons is that does not depend what was the stage of diagnosis. Still, chemotherapy together with pembrolizumab increased the effect of the complete pathological response. And for me, it was very important to understand that patients with the nodes involved, the percentage of the complete pathological response was high because they were in the high risk of relapse. And different from metastatic disease in Keynote 522, with the triple negative breast cancer, there was no dependence from the efficiency using pembrolizumab. And more important issue, when we speak about events in Keynote 522, any event was determined as event. Again, it is relevant to the aggressive forms of breast cancer. Very frequent there were relapses of the remote metastasis. It increases the importance of neoadjuvant treatment. In this point, we should provide the optimum treatment to decrease the risk of relapse, especially in metastatic diseases. Now, regarding the neoadjuvant application of pembrolizumab, analogical to other studies in patients who got the complete pathological response with or without pembrolizumab, the response was good. But patients who did not get the pembrolizumab, so they decreased the relapse risk. So we should be very careful about interpretation of this graph, because there is a big percentage of patients who did not reach PCR, but there is a tendency still. Regarding the safety and the side effects, the majority of the side effects developed in adjuvant stage, but there is no increase of the risk like in chemotherapy. The majority is in immune-related. We were part of that research. We had 15% of patients who were included into the Keynote 522 study. So the correction of the side effect was easy, and it enables us to say that pembrolizumab in neoadjuvant setting is bearable. We should explain and we should monitor the side effects. What about the positive effects? Do we really need anthracycline? There is the second phase called NeoPACT. So we used pembrolizumab with toxins in this setting, and we see that we reached the parameters in majority of patients. They showed the complete pathological response, and the majority of patients showed good results with the nodes involved. They are the high risk. There is one more confirmation that pembrolizumab together with the chemotherapy is the optimum approach to treat patients. And again, when we see the remote forecast in survival, the patients with a complete response, the forecast in relapse is much better. So, to summarize, pembrolizumab is the one and only immune inhibitor of control points that is currently allowed in combination of therapy of ACNT together with carboplatin. The main is anthracycline, and toxins are provided once in a week or once in 2 weeks. In rare cases, in case there is a contradiction to use anthracycline, you can use taxans, carboplatin, and it's not a standard. This is an option. In the future, there will be new options studied. The combination together with the radiotherapy in different dosage. And patients having triple negative breast cancer together with BRCA1 and 2 or PALB2, it's in combination. And we know that there are new players in triple negative breast cancers, combined molecules with antibodies and antitoxic medications. And antituzumab is allowed to use for triple negative breast cancer treatment, and now it is assessed in the early stages. A neoadjuvant treatment of triple negative breast cancer. If we have already made maximum level and still did not reach the necessary level, which way can we neutralize the effect? The capecitabine in TNBC got the adjuvant treatment, and in case you do not get the response. This is the only study that is called CREATE-X in patients who got the adjuvant capecitabine in case of TNBC, and they got the improvement in overall survival. The Olympia trial, and it improves our approach to treat patients with early forms of breast cancer and with hormone mutation BRCA1 or 2. And in Olympia trial, the patients with triple negative breast cancer, they should get olaparib during 1 year. And what's important here, the patients got olaparib, they showed decrease of all types of relapse, and overall survival benefit means improve of overall survival. Olaparib is now a standard approach to treat the patients with the TNBC or ERPR with a high risk of relapse and BRCA1 or 2. Keynote 522 we have already discussed. In patients who has not reached that level, this is for the
for tramipzolab, 60-70% of patients receiving carbolizumab versus those who did not receive pembrolizumab. And another important outcome is that first we have full pathologic reaction, but on the other hand, there is a specific move not only in terms of pathologic complete reaction, but a minimal risk dual volume of residual volume of tumor. It's better than without this treatment. Their prognosis is better, and we see as less residual volume of tumor as better the prognosis. Now, specific questions which we are raising as a result of these clinical studies, which one is most effective, or their combination, olaparib and pembrolizumab. We have a lot of evidence on PARP inhibitors. As far as PARP inhibitors with xylotocazepine, we don't have any data on efficacy and safety at early stages of disease for these drugs. In order to make a proper, correct choice, for instance, if it is the TNBC, and maybe we can give PARP inhibitor, because there we have, we still not have overall survival rate data. This means we have to approach case by case to every patient. We can finish pembrolizumab pembrolizumab and then providing olaparib, because in Olympia they started receiving olaparib after 3 weeks after completion the initial treatment. And here we have algorithm for TNBS early stage cancer, again with more than 2 centimeters tumors and with nodes affected, should have standard chemotherapy with lampromazumab, or then patients with 1.52 centimeters tumor, they have received pembrolizumab, and with TCB DDAC, they have to focus on olaparib, and without mutation, they have to have pembrolizumab with temozolomib. I want to thank you for your
Спасибо большое, но нам нужно провести вначале посттестирование, а потом, я думаю, вопрос...
And after this, we will have a look
посмотрим, надо, ну, такая процедура.
On behalf of the audience. So, yes, there it is. It was
Я думаю, что их можно не зачитывать, потому что, в принципе, они высвечиваются у всех на экране, и можно просто выбрать, и у нас очень сократится время для голосования, и сразу вывести результаты голосования зала на экран спикеру. Я, извините, влезла в модерацию.
I apologize for interrupting with my moderation attempt.
Уже есть. Уже можно комментировать, то есть поменялись ли какие-то...
We see some changes. I think last time, before my lecture, it was more C, but actually there is not a tremendous changes in the responses.
100%.
Here we have 100%, that is 100% success. And the last question.
Не поменял, все, да, аудитория ответила точно так же.
In Kazakhstan, pembrolizumab will be used for early stages, triple negative cancer, and I think it is very beneficial.
Вы, пожалуйста, не уходите, но Аполлон на вопрос хочет.
There is a question over there.
Thank you very much for your very comprehensive overview of the whole treatment, starting from the neoadjuvant to the adjuvant of triple negative breast cancer. If the audience has any questions, I see, Doctor, you have a question?
Нина Аполлоновна.
Нина Аполлоновна, do you have questions?
Знаете что, Рита?
Микрофон.
Скажите, пожалуйста, я, извините, что я не уловила, какими препаратами вы высокодозную проводили. Это, во-первых. И потом, получено ли, я как-то почитала, я здесь реферат себе составила, что высокодозная химиотерапия составляет 82%. Вот так, по-моему, да? А другие стандартные схемы 75%, то есть разница всего 7%. Стоит ли за 7% увеличивать, допустим, побочные эффекты? Хотя бы вас говорят. Это во-первых. А во-вторых, вот у нас, по крайней мере, не у нас, а вот есть в литературе данные, что высокодозная химиотерапия не показана при тройном негативном раке. Вот так написано просто. Почему? Потому что она убивает, допустим, чувствительные клоны, а оставляет только вот, немножечко клоны, которые очень агрессивные, и они быстро потом агрессивно растут. Или это не касается предоперационной химиотерапии? Может быть, это касается вообще-то распространенных форм? Спасибо.
the most popular grades of cancer. In Kino 222, adrenocitmab 2 or 3 weeks with pembrolizumab at the same time. And in current, we have AC 2 times a week and pembrolizumab several times a week, not changing the regimen. 7% is absolute benefit, which is significant. We've got from CNF with AC with less absolute benefit was 2% at that time. And also we had important meta-analysis ABC trial, which is a combined meta-analysis of 3 adjuvant trials, and the SKY relapse risk as better the benefit of using anthracyclines. Anthracyclines with high-risk patients, yes, for higher doses, and not all cells are reactive, but this is true for TNBC, HER2 positive, and where heterogen component of any tumor is one of the most problematic issue in cancer treatment, especially for TNBC, which are chemosensitive, they live, and those which stay there. The mutation in residual diseases of SKY, which means that non-responsive tumors are more tend to mutate. That is about the high grade of tumor rather than the chemotherapy effectiveness. We should not abandon chemotherapy for these patients, but we need to overcome the initial heterogeneity of tumors, and pembrolizumab is one of the approach. X-ray therapy is another thing, and I also believe sacituzumab is a new ADC which demonstrates significantly higher efficacy in metastatic TNBC. And once we overcome this heterogenic sensitivity, then we could approach this heterogeneity. We should not abandon chemotherapy for these patients, but rather overcome the heterogeneity.
Большое спасибо, Рита. У меня вопрос, как вопрос от патолога, вообще судя по результатам всех тех клинических исследований, которые вы сегодня продемонстрировали, и, в общем-то, отсутствие разницы, скажем так, в оценке PDL-1 и кат-оффе, там больше 1, больше 10, да, в качестве предиктора имеется в виду для пембролизумаба. Является ли это действительно таким выводом для нас, что исследование на PDL-1 является необходимым? То есть это ведь не обязательно на сегодняшний день. Тестирование PDL-1. И делаете ли вы его?
Thank you, wonderful question. And within the clinical trials, and we will 5-2K note, we did this because this was the requirement of the clinical trial. Now, as a standard practice, we do not do PD-L1 expression tests for TNBC patients early stage. And pembrolizumab of early stage is prescribed irrespective of PD-L1. Whether it is interesting, I think yes, because from my perspective, and again, this is my approach, if we have a look at scale of 5-2 with PD-L1 higher level patients, they have higher TILs level, and if there's no direct correlation to sensitivity to pembrolizumab, the higher, more dramatic response were in those group which did not receive pembrolizumab. Maybe this is kind of predictor of whether the tumor will be sensitive to chemotherapy. I have no answer either yes or no. I would continue this, but would not depend pembrolizumab in the early stages for TNBC, depending upon the expression of this. But PD-1 expression is much higher. It is more, practically 70% versus TNBC when this expression decreases. Maybe this is because of a difference
Огромное спасибо.
sensitivity to
Можно еще вопрос
chemotherapy,
такой?
different response rate to
Во-первых, я
chemotherapy.
хочу поблагодарить вас действительно за
First of
такую
all,
обзорную,
I want to thank
очень
you
объемное
for this comprehensive
выступление у вас. Прям еще раз говорю большое спасибо. У меня два вопроса по поводу, да, интересное исследование дурвалумаб. Есть ли у него перспектива? Да, то мы понимаем, пембра побеждает во всех направлениях, в том числе при breast cancer. И второй вопрос по поводу PARP-ингибиторов. Да, олапариб, а вот талазопариб, его возможности, можете про него сказать сравнение, и есть ли опыты? Вот потому что есть исследование, что эффективность талазопариба выше вот в этом направлении. Спасибо большое.
Patients with BRCA mutation TNBC received talazoparib as neoadjuvant, and PCR percentage was quite high after 3 months of treatment. And whether future for this drug, yes, as more trials will be available, proving efficacy in a bigger amount of patients. Durvalumab, yes, undoubtedly, there is different stages of trials, which olaparib with durvalumab combination in early stages TNBC with higher and moderate risks with tumors less than 2 centimeters. They will receive olaparib as neoadjuvant, but with more than 2 centimeters, they will receive durvalumab with olaparib. And that means the answer is yes. The future depends upon these trials, but the combination of immunotherapy with PARP inhibitors for BRCA1 and 2 terminal termination mutations is one of the most important focus of this
Очень интересная тема.
Yeah, because this was a wide revision. The topic is really huge, so a lot of interesting questions. I would like to ask you about, as I understand, in a standard of care for the neoadjuvant, you regularly and basically use pembrolizumab, right? I'm correct, yeah, yes. So in case of pathologic complete response, I just want to address the Keynote 522 trial. It was designed in a way to continue pembrolizumab in adjuvant setting regardless of PCR status. So to this date, yes, we know that event-free survival was better, but we don't know what was the impact of post-surgical treatment in adjuvant setting, right? You understand me? So we don't know in this situation. And also taking into account the other studies that are running, and you mentioned also the Geparneu study with durvalumab, where after pathologic complete response, they don't continue adjuvant treatment, and they showed the similar efficacy. So do you mind, I just want to listen your personal opinion, do you mind, maybe we can omit pembrolizumab in adjuvant setting, particularly maybe in countries where pembrolizumab is not available and where is a huge problem with financial support, financial issues of pembrolizumab?
I really don't know. We have now enough data supported early discontinuation of pembrolizumab in adjuvant setting. We should wait for additional trial comparing pembrolizumab, yes or no, in adjuvant setting for patients with pathological complete response. But currently, what I can say is that for patients who experienced pembrolizumab immune-related side effect, and as a result, we had to interrupt pembrolizumab therapy, and they demonstrated pathological complete response, I feel better. They know that the pathological complete response is a predictor for overall survival benefit, irrespective of the treatment that we choose for neoadjuvant therapy. So I'm not sure that without a side effect, I will recommend to interrupt therapy for patients with pathological complete response and not to complete 9 cycles of pembrolizumab in adjuvant setting. I will complete it.
Thank you very much. And the second scenario, when we don't have pathology complete response and we have a residual tumor. The paradigm of neoadjuvant therapy is like if the treatment is not responding, if the disease is not responding and we have a residual tumor after any kind of treatment, we don't consider this treatment as effective for the future. But yes, we know the data. We know that you showed us clearly that even those patients who do not have pathology complete response, they still benefit in adjuvant setting. But do you mind that volume of residual disease may play a role? Yeah, possibly for those patients who are not responding at all, maybe for those patients it's not necessary.
I have known an answer, but the only confirmed treatment that we have for those patients with non-responders with RCB3, 2, the only option that we have currently is capecitabine. I'm not sure the capecitabine alone is better than pembrolizumab with capecitabine, that we have enough data from metastatic disease to use concurrently pembrolizumab with capecitabine. And for those who didn't respond, I'll go to capecitabine with pembrolizumab. There is no better option.
Thank you very much.
Thank you very much.
Thank you very much.
Дорогие друзья, мы закончили.
Dear friends, we are finishing our session, and to finalize, still, let me pass the floor to summarize by Nati, to make an overview of all the reports that we have.
Okay. First of all, I would like to thank all presenters for really very interesting presentations. All reports were of great interest. Ongoing studies covered by these topics are at final stage of investigations, and hopefully after completion of clinical trials, we will see them in our standards of care. And now I was asked to summarize our session, and with the principle repetitio mater studiorum, we repeat everything what we've learned now. So the first abstract presented by Dr. Carmin was phase 3 NATALIE trial of ribociclib plus endocrine therapy as adjuvant treatment in patients with HER2-positive, HER2-negative early breast cancer. From this report, we learned that now we have another option to add to the adjuvant endocrine therapy in high-risk breast cancer patients. In NATALIE trial, addition of ribociclib to one of the non-steroidal aromatase inhibitors for 3 years improved invasive disease-free survival from 87% to 90%, which is a 3.3% benefit. And there is a trend to improved overall survival, but overall survival data are not mature yet, just 30 months follow-up, so we will see them next years. Okay, one important topic was that it should be that the dosing of ribociclib, 400 milligrams dose, was lower than used in metastatic setting, and it was pretty good tolerating during the treatment without compromising efficacy. This is a key message here. The second report was about the primary efficacy analysis of NEORIA study, neoadjuvant biomarker research study of palbociclib combined with endocrine therapy in estrogen receptor positive, HER2 negative breast cancer. In this work, we see the dependence of effectiveness of neoadjuvant palbociclib combined with endocrine therapy on a level of biomarker expression. This was the phase 2 study evaluating 2 months of neoadjuvant palbociclib in endocrine therapy. Was the primary objective to identify biomarkers of no response, and that were the messenger RNA of CDK6 genes by locally assessed ultrasound using RNA sequencing on baseline tumor biopsies. Secondary endpoints included residual tumor burden and the absence of complete cell cycle arrest, defined as Ki-67 by immunohistochemistry. And as a result, high pretreatment messenger RNA expression of CDK6 gene was associated with no ultrasound response or absence of completed cell cycle arrest in a patient treated with neoadjuvant palbociclib and endocrine therapy. The third abstract was presented by myself. It was about efficacy and safety results by age in monarchy, adjuvant abemaciclib combined with endocrine therapy. Monarchy was designed to evaluate the addition of 2 years of adjuvant abemaciclib to endocrine therapy in high-risk early breast cancer, which is hormone receptor positive and node positive, so high risk. The objective of this analysis was to explore the efficacy and safety of adjuvant abemaciclib in a subgroup of older patients that were enrolled in the study. Efficacy, safety, and patient-reported outcomes were conducted in 2 age groups, those who were under 65 years and those who were over 65 years of age. And older patients, as a result, the older patients derived similar abemaciclib benefits to the intention to treat population. In patients who were under 65 years of age, invasive disease-free survival was improved by 6.7% absolute magnitude of benefit, and those who were under over 65 years of age, IDFS was improved by 5.2% magnitude of benefit. In terms of distant recurrent-free survival, was a similar story. Adverse events were also similar between age groups. However, grade 3 or more severe diarrhea and 5% was 5% more frequent in elderly population, and we need to pay attention to this. Similarly, grade 3 fatigue was also higher in older patient group. And the last abstract was presented by Dr. Rita Toker. It was about the neoadjuvant therapy in a triple-negative breast cancer, and the main messages here is that neoadjuvant chemotherapy is now the standard of care in the treatment of triple-negative breast cancer. I mean the stage 2, stage 3 triple-negative breast cancer. Effectiveness of neoadjuvant chemotherapy is evaluated by pathologic complete response, which is associated with improved survival outcomes. Next message was that dose-dense chemotherapy has 4-year recurrence-free survival advantage, 82% versus 75% over the standard 3-week regimen. Weekly paclitaxel is better than 3-weekly in terms of relapse-free survival. Also, adding carboplatin to taxane anthracycline backbone increases PCR in these triple-negative breast cancer patients. Also, perioperative immunocheckpoint inhibitors are the standard of care in stage 2, stage 3 breast cancer. And in case of contraindication to anthracycline, carboplatin, taxane, and pembrolizumab should be considered as a standard of treatment, and PARP inhibitors are under the development in the neoadjuvant setting. So thank you very much for your kind attention. Hope this session was very interesting and productive for you.
Спасибо большое. Thank you very much. Thanks a lot for the today participation, and especially Thanks a lot to the distinguished guests. Thanks a lot, dear speakers. The lunch break is now. It will be in the main building of the hotel, in the restaurant of the Royal Tulip Hotel. You should walk outside this building and go to the next building. Thank you.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. KazCS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Давай, проверь. Қонақтар шақыр, ішке кірсін. Бәрі ішке кірсін, шақыр.
Қалай шақырамын?
Қонақтар ішке кіріңіздер, орындарыңыз жайғасыңыздар.
Не
работает. Dear summit participants, please go to the hall and take your seats.
Ішке кіріп, өз орындарыңызға отыруларыңызды өтінеміз. Мына айтып қой. Кіріп қой, мына кім болады?
Dear participants, let me introduce our next moderators to Indira Omarova, Kaldugoy Smagulova, Karmin Dangilis.
Құрметті Индира Омарова, Қалдыгүл Смагулова, Кармин Ангелис, сіздерді симпозиумға модераторлық ету үшін подиумға өтулеріңізді өтініп сұраймыз.
Коллеги, мы начинаем. Good day to all. We continue for our conference, a section of metastatic breast cancer. For 2.5 hours, we plan to discuss topical issues in the treatment of metastatic breast cancer, modern possibilities of drug therapy for hormone-positive metastatic breast cancer, HER2-positive and triple-negative breast cancer, and a very interesting topic from Maya Djugashvili, breast cancer oligometastasis. I think it will be very interesting, and so the first presentation, second line endocrine therapy with or without palbociclib maintains in patients with hormone-positive HER2-negative advanced breast cancer, pulmonary trail, Anwar Al-Nouri, MD, FRCP, consulting medical oncologist, Kuwait Center Control Center, Kuwait. Please, Anwar Al-Nouri.
Good evening, or good afternoon, I would say. Thank you, Mr. Chairman, for the nice introduction, and thank you for the organizers for the invitation to be here. It is my first time in Kazakhstan, and it's really a big pleasure to be here. So I will be presenting the second-line endocrine therapy with or without palbociclib maintenance in patients with HR-positive, HER2-negative advanced breast cancer, the Palmyra trial. I will start the talk with 3 questions, and the first question, if you can scan the code with your phones, you will see the question. And the first question, what drug was used in the group of patients without maintenance therapy in the Palmyra trial? 1, palbociclib, 2, tamoxifen, 3, letrozole. Okay, so the second question, primary endpoint measured in the Palmyra trial, was it improved of overall survival, no disease progression, or the improve of quality of life? So I can see here from the results, majority of people are choosing A for the first question, which is palbociclib. So I'll go through the trial and we'll see if we can get changes in the answers. Now for the second question, the primary endpoint measured in the Palmyra trial, was it improved of overall survival, no disease progression, or improvement in the quality of life? And as I can see also here, majority chose A, 50% of the audience, and we'll go through the trial and see if we can change the answers also. and 25% between B and C. The final question, results of the Palmyra study. One, was it patient receiving maintenance therapy with palbociclib had significantly longer progression-free survival, or patients receiving maintenance therapy with palbociclib did not differ in PFS from the patients with placebo? And the third option, maintenance therapy with palbociclib did not significantly improve on the progression-free survival. So now I start with the talk. Again, the title is the second-line endocrine therapy with or without palbociclib maintenance in the patients with HR-positive HER2 negative advanced breast cancer, the Palmyra trial. These were the declarations of interest of the original presenter in the ASCO 2023 in Chicago, Dr. Antonio Lombard. So as we all understand that the combination of endocrine therapy with CDK4 inhibitors has become the standard of care as the first-line therapy, with the abundance of the evidence that we have in terms of the PFS and the OS with these agents. We also have not a clear understanding of the optimal treatment after progression of the first line. It still remains undetermined, and although the endocrine sensitivity persists after the CDK4/6 inhibitors regimens, the preliminary findings suggest more adaptive resistance mechanisms to endocrine therapy rather than the CDK4/6 inhibitors. So the Palmyra trial aims to determine whether maintaining palbociclib with an alternative AI, endocrine therapy, so changing the endocrine therapy but maintaining the CDK4/6 inhibitor, improves the anti-tumor activity of the second-line endocrine therapy in patients with HR-positive HER2 negative advanced breast cancer progressing on the first line. And this is quite of a tiebreaker trial, because we had similar trials that showed conflicting data with the maintain and the PACE trials, where one showed that there's a benefit of continuing with the maintain trial, where the PACE did not show that. So this is like a tiebreaker between those two trials to see whether there is a benefit of continuing the CDK4/6 inhibitor. And this was the design of the trial, as you can see. So the inclusion or the key eligibility criteria for the patients, they were patients with HR-positive HER2 negative breast cancer. They had to have had progressed on the first line palbociclib plus an endocrine therapy, either AI or fulvestrant. After clinical benefit, majority of the patients were AI. There were patients who were on first line with fulvestrant because of the Parfisal trial, where they were trying to see if there's any difference of the endocrine therapies with the CDK4 inhibitors. And also another patients who had progressive disease on palbociclib as an adjuvant. And there were 2 patients on this cohort were included in the trial. And they should not have had any other prior treatments for the advanced breast cancer. And they were stratified or randomized, 2-to-1, to either receive fulvestrant or letrozole, depending on what endocrine therapy they were having in the first line, with palbociclib maintaining the same CDK4/6 inhibitor drug. And the dose was depending on the last dose they were on in the first line, so whether it was 125, 100, or 75, versus the same either endocrine therapy group, either fulvestrant or letrozole without the palbociclib. So just endocrine therapy alone. And this was continued until disease progression or unacceptable toxicity or study withdrawal. And the primary endpoints were looking at the PFS. So if you look at the other selection criteria, they had, that other than the ones I mentioned, they had measurable or evaluable disease based on RECIST criteria, so they had to have that. And also they had an ECOG performance status of 0 to 1. Exclusion criteria, of course, included visceral crisis, any previous treatment for advanced breast cancer out of the first-line palbociclib regimen, and use of CDK4/6 inhibitors other than palbociclib, and resistance criteria for both fulvestrant and letrozole. And these were the study endpoints. So the main endpoint, the primary endpoint, was looking at the PFS, determined by the RECIST criteria. Other endpoints looking at objective responses rate, clinical benefit rates, overall survival, duration of responses, and time to response and the time to progression. And also the same endpoints prior to endocrine therapy, site of disease, so based on certain stratifications. Now, looking at the statistical considerations, the efficacy was assessed in all patients who had undergone randomization. The Kaplan-Meier method was used to estimate the PFS, and the sample size was based on the superiority test of the PFS. It was estimated that with an enrollment of 198 patients, the trial would have an 80% power to detect a 2.74 months increase in the median PFS over a 4 months median PFS for the endocrine therapy group. So this was a summary analysis of the population. As you can see here, 136 patients were allocated in the endocrine plus palbociclib group. Majority of the patients had discontinued treatment, around 81.5%, and majority of those discontinuation were because of disease progression. And the median follow-up was 13.2 months. And if you look at the baseline characteristics in the intention to treat population, they were well balanced on both sides, whether you were looking at the premenopausal or postmenopausal, which were the majority of the patients, postmenopausal, or if you're looking at the ECOG performance status score, measurable disease, or the visceral involvement. Majority of the patients had visceral disease, around 2/3, and 1/3 did not, was only bone disease. And again, when you look at the baseline characteristics, they were, again, well balanced on both sides in regards to if you're looking at the prior endocrine therapy, which was majority of them, they were the AIs. To a lesser degree was fulvestrant, around 10% only. And then also the duration of the treatment in the first line, whether they were on the treatment as the first line for more than 12 months or less than 12 months, between 6 and 12. And as you can see, this is the final result of the primary endpoint, which was the primary objective of the trial, which is the PFS in the population. And as you can see, that a median PFS of 4.9 for the palbociclib group compared to 3.6 in the endocrine therapy alone group. You can see that, interestingly, that at 6 months, you can see that there's a greater benefit for the palbociclib favoring numerical benefit. However, overall, statistically, this was not significant. And if you look at the subgroup analysis, there is a tendency to preference of palbociclib. However, this is by far not statistically significant in any of the subgroup analysis at all. If you look at all of them, you can see that they cross the line. Now, when you look at the PFS by visceral disease, so certain stratifications, so you can see interestingly here that the patients without visceral involvement had a greater benefit in both arms in regards to the PFS. You can see in the palbociclib group 8.8 months compared, and in the endocrine therapy it is 4.4 months, where you can see on the other side the visceral was much less. However, when you look at the hazard ratios, they were much deeper in the visceral involvement with a hazard ratio of 0.78 compared to the hazard ratio with the visceral metastasis of 0.92. And then again, when you look at the PFS by prior duration, you can see that there's a benefit in both arms in the patients who had longer treatment in the first line. So the patients who had palbociclib with endocrine therapy for more than a year, more than 12 months, had a greater benefit in continuation. But again, this was numerically not statistically significant. When you look at other efficacy endpoints, there was no benefit if you're looking at the objective response rate. So, for example, if you're looking at the partial responses, or if you're looking at objective response rates, you can see that there's slightly a benefit for the palbociclib group, but they were small on both sides. 6 patients on the palbociclib group, 1 patient for the objective response rate in the endocrine therapy group. However, if you look at the clinical benefit rate, there was a favoring the palbociclib compared to the endocrine therapy in terms of the clinical benefit rate. As you can see, 57 compared to 17, or I would say in percentage-wise, 41% versus 27. And this translates into the overall survival. You see that the lines remain pretty much close to each other, with no statistically significance in any of the in this secondary endpoint, which is the overall survival. Safety analysis, there is nothing that we did not already know about in regards to the safety analysis or side effects, adverse events. You can see in regards to the difference of grade 3, grade 4 adverse events. And the second line here, comparing the endocrine therapy with the palbociclib, and these were majority hematological side effects, so that's why you can see the big difference between them. But otherwise, there was nothing new that we didn't know about. And when you look at the treatment-related adverse events by maximum severity, you can see the majority of the patients with the palbociclib group had hematological toxicity. So over 80% of the patients in terms of all grades. And we know from previous trials that they were up to a third of them were grade 3 or grade 4, about 5% of hematological toxicity, mainly neutropenia. Also another non-hematological side effect, which is important, that we see now on longer durations of the patients with the palbociclib, which is the fatigue. However, the fatigue is, majority of them are grade 1 and grade 2 fatigue. We don't see more than that. So in conclusion, palbociclib maintenance strategy following progression on a first-line palbociclib regimen did not improve the PFS compared to standard endocrine therapy in patients with HR-positive HER2 negative advanced breast cancer. The PFS analysis showed no significant difference across all pre-specified subgroups. However, clinical benefit rate, as I mentioned in the table, and PFS rates at 6 months, as I showed you in the graph, as well as the activity in patients with aggressive disease, suggest that a subset of patients may benefit from palbociclib maintenance. There were no unexpected safety signals that were identified, and we need a biomarker study program to which is already underway, to identify which patients are most likely to benefit from a CDK4/6 inhibitor maintenance strategy. Now we go back to the questions again. I will ask the same 3 questions. So the first question, if you can just scan the code. So what drug was used in the group of patients without maintenance therapy in the Palmyra trial? So the question again is the group without the maintenance therapy. So the group that did not include the palbociclib. So we have majority of the answers are A. So actually the answer is C. And again, maybe the question wasn't so clear, but it's the drug that was tested, not in the maintenance, was without the maintenance. The maintenance was the palbociclib, so the question was regarding the endocrine therapy. So it's actually the answer is C. The second question, primary endpoint measured in the Palmyra trial. So a third have the correct answer with which was the no disease progression. The overall survival was a secondary endpoint. And the third question, results of the Palmyra study. So the correct answer is the first, which is A, so 33%, which was patients receiving the maintenance therapy with palbociclib had significantly longer progression-free survival. So yes, 67% with the correct answer. Thank you.
Thank you very much, Anwar Al-Nouri. Вопросы, коллеги?
Questions?
colleagues' questions.
If no more questions, let us continue. And the floor goes to Carmine De Angelis, онколог в онкологическом центре Азиенда Оспедальера, Университет Фредерика II в Италии.
Negative advanced breast cancer, analysis of all 3 cohorts of the BELIEVE study.
Альпилисип, эндокринная терапия пациентов с PIK3CA мутациями. Ну что ж, спасибо. И теперь настало время наших традиционных вопросов до презентации. Понимаю, что это тяжело после обеда тяжело. Но мы должны... Название многоцентрового открытого исследования второй фазы без сравнения апелисиба плюс ЭТ у пациентов с мутациями PIK3CA, HR положительные, HER2M, РМЖ, включающие пациентов с прогрессирующим заболеванием во время или...
And third one is which adverse events of special interest appeared during using alpelisib. So the first one, they have been chosen the answer C by 67%, so by leave. The second question, okay, 67% choose A, so we need to show better carefully the study design. And question 3. Okay, so question 3 is the 83% answer A, so hyperglycemia, diarrhea, and rash. Okay. So, can I have the slide, please? I cannot see here the slide. Okay, so the trial that I'm going to present actually is in the same setting of the one that Dr. Al-Nuiri showed you before, the Palmyra trial, means the progression after CDK4/6 inhibitor in the first line that we know that actually is the standard of care for patients with hormone receptor positive, HER2 negative advanced breast cancer. So the combination of endocrine therapy plus CDK4/6 inhibitor. And it's good to recall that this combination improves progression-free survival, response rate, and for 2 drugs also overall survival, ribociclib and abemaciclib. But what is the problem? That while this treatment is so effective, a little portion of patients are de novo resistant, and the majority of patients ultimately develop acquired resistance, and the disease of this patient progress. And underlying the mechanism of resistance to endocrine therapy and alone or in combination with CDK4/6 inhibitor, there are several mechanisms that have been described. One of these mechanisms is represented by the alteration of the PIK3CA AKT-mTOR pathway. That is a critical pathway that is involved in several mechanisms, including cell proliferation, apoptosis, metabolism. And we know that mutation in the gene that encodes for the subunit alpha of the PI3 kinase, the gene is called PIK3CA, represent the major cause of the alteration of the PIK3CA AKT pathway, and is recognized, is found in around 40-45% of patients with hormonal receptor positive, HER2 negative advanced breast cancer. And we know, our group and others,
show that the alteration of the pathway is associated with resistance to endocrine therapy. So several drugs have been developed for targeting the PI3 kinase pathway, the PI3 kinase specifically, but only one, the alpelisib, that is a selective alpha-specific inhibitor of the pathway and a degrader of the PI3 kinase, and also a degrader of the PI3 kinase, have been approved in combination with fulvestrant for patients with PIK3CA mutated ER-positive, HER2-negative metastatic breast cancer based on the data from the SOLAR-1 trial. The SOLAR-1 trial was the trial that showed that the addition of alpelisib to fulvestrant in patients with metastatic endocrine-resistant breast cancer was superior to fulvestrant alone, especially in patients with PIK3CA mutation. And this was a significant benefit in terms of progression-free survival, with a median PFS of 11 months versus 5.7 months of the fulvestrant, and also a numerical increase, but not significant increase in median overall survival. But when the SOLAR-1 trial was conducted, the CDK4/6 inhibitors were not a standard of care in the metastatic setting, so only a small percentage of patients, 6% of patients, 5.9% of patients, had prior CDK4/6 inhibitor treatment. So the question is that, is alpelisib also effective in patients who receive CDK4/6 inhibitor? And that's why was designed the BYLieve study. So the BYLieve study is a non-comparative 3-cohort phase 2 study examining alpelisib in combination with endocrine therapy in patients with PIK3CA mutated ER-positive, HER2-negative breast cancer who disease progressed on or after prior treatment, including treatment with CDK4/6 inhibitor as immediate prior therapy in 2 of the 3 cohorts. So the 3 cohorts that I'm showing you in a second. Here, okay, you can see the cohort. So we have the cohort A, where alpelisib was combined with fulvestrant in patients who progressed to aromatase inhibitor plus CDK4/6 inhibitor as immediate prior treatment. Cohort B, where alpelisib was combined with letrozole in patients who received prior CDK4/6 inhibitor plus fulvestrant as immediate prior treatment. And then we have cohort C, where alpelisib was combined with fulvestrant in patients who progress on or after AI and receive chemotherapy or endocrine treatment as immediate prior treatment. So we have 3 different cohorts, non-comparative cohort. This is a phase 2 trial. So we already know some data about the BYLieve study. So the data that were present in the ASCO were the exploratory and analysis of with a median follow-up of more than 18 months. And the primary endpoint of this trial was was the proportion of patients with centrally confirmed PIK3CA mutation alive or without disease progression at 6 months per local investigator assessment per RECIST criteria. And the primary endpoint was met and clinical meaningful if the lower bound of the confidence interval was superior to 30%. And we know that the trial met its primary endpoint. Regarding the analysis set, this is important to remember that the full analysis set FAS and safety set comprise all patients to whom study treatment was assigned and who receive at least 1 dose of study treatment. And then we have a modified full analysis set, MFAS, that comprise all patients of the FAS who received at least 1 dose of the study treatment but had a centrally confirmed PIK3CA mutation in tumor tissue using a PCR detecting mutation in the exon 7, 9, and 20, respectively. It was a centralized way to be sure that patients have really a PIK3CA mutation. So the table is pretty dense, but we'll go through it. Is that just to show the characteristic of the population. So almost all patients except 1 were female patients. 78%, 95%, and 85% of patients, respectively in cohort A, B, and C, were postmenopausal, so the majority of patients of the trial were postmenopausal. Around 65 to 75% of patients had visceral disease, so these are patients with poor prognosis, and also between 9 to 18% had only bone-only disease. And finally, between 18 to 63% of patients receive several two or more lines of prior therapy in the advanced setting. So these are the update analysis of median progression-free survival and overall survival. You can see that the treatment is effective, and we have not significant because it is not comparative, but if we compare this data in terms of progression-free survival and overall survival with the other data coming from trial in the same setting, we can see that the drug actually is effective. And an interesting analysis that has been conducted was to test potential difference if the treatment, the combination of alpelisib plus endocrine therapy, was given in a second line or third line, because as I mentioned before, patients were included both in a second or in third line. And as you can see in the slide, in the table, there is no difference between second line and third line in terms of PFS in cohort A and cohort B. That I recall you, cohort A is alpelisib plus fulvestrant, and cohort B is alpelisib plus letrozole. So you can see there is not difference. But if you see in cohort C, that is alpelisib plus fulvestrant in patients who receive prior chemotherapy or endocrine therapy alone, you can see a numerical increase in terms of PFS. And a numerical difference between second line and third line is more evident in terms of overall survival, if you see on the bottom of the table. And this difference is clearly seen, especially in cohort A and cohort B, where the difference was around 6 and 10 months, respectively, if we give treatment in second line, or on third line. Regarding safety, there was no, the safety are summarized in the table, and most of the serious adverse event, I mean, the safety profile of the drug, of the alpelisib, was well known, and there was no new signal of new safety concern and adverse event. And the more frequent alteration, adverse event were hyperglycemia, rash, and diarrhea, and these are consistent with what we already know about the drug. But was it interesting to see that these patients were followed these three side effects, so hyperglycemia, diarrhea, and rash, are the adverse event of special interest, because they are associated with the on-target effect of the PI3 kinase inhibitor. So if you look here, you can see actually that the hyperglycemia and the rash tend to the incidence you see that goes down after the first month of treatment. So, and while, for example, for diarrhea, if you look in the diarrhea, most of the grades equal or more than 3 are very low. So the frequency is less than 3.5%. So, and this, ensure us about the fact that this drug can have some side effect, but we know, probably we learn how to manage this treatment. And also, looking at the fasting plasma glucose levels, that are again associated with the on-target effect of the alpelisib, we can see that the incidence of hyperglycemia and the peak is reached by cycle 1, day 8 and day 15, and this is true in all cohort, but then stabilize over time, and this is regardless of the baseline glucose level of the patient. So the patient are divided by normal glucose of pre-diabetic status, and you can see that it is the same and is stabilized over time. So in conclusion, at the 18-month follow-up data, all three cohorts of the BILIVE study indicated that alpelisib in combination with endocrine therapy may be an effective treatment for patients with PIK3CA mutated hormonal receptor positive HER2 negative breast cancer. This after progression on or after prior treatment, including CDK4/6 inhibitor, and we have seen also prior treatment with chemotherapy. Patients treated with alpelisib plus endocrine therapy in second line, so immediately following progression to CDK4/6 inhibitor, experienced longer median overall survival compared with patients that were treated with the combination in third line, and this potentially demonstrates that there is an increased benefit in the benefit of the combination when we give early as possible. And the adverse event, I show you that the adverse events are well characterized, are manageable and predictable. So when we are going to give a patient alpelisib, we already know what we are going to expect. And also we've seen that at 18 months now we have we saw a decrease in the incidence of all grade adverse event of special interest, hyperglycemia, diarrhea, and rash. And among these, we saw, for example, that the diarrhea was really low, the rate of the treatment. So this treatment is an effective treatment. Now is ongoing a phase 3 trial comparing alpelisib plus fulvestrant versus fulvestrant alone in patients who progress to endocrine therapy plus CDK4/6 inhibitor. The name of the trial is EPIC-B5. That are need to fully register the alpelisib in a metastatic setting after progression to CDK4/6 inhibitor. This finding also opened the need of starting to learning how to measure and find the mutation that could be found in the blood and in tumor tissue. And also we know now how to manage side effects, and there are, for example, the use of prophylactic metformin to prevent the hyperglycemia, has shown in the Metallica study that reported a low incidence of adverse event associated with hyperglycemia in patients who receive alpelisib. Thank you for your attention, and now I will ask you to scan again the code. There? Here? Okay, so the first question was multicenter. So what is the name of the trial that I just showed you? So really fast. So the second question is how many cohorts of patient were in the BILIVE study, and third one is which adverse event of special interest we see during alpelisib treatment. Okay, so the first question is BILIVE. Okay, that's correct. 94% are correct. So it's the BILIVE trial. The second question, how many cohorts? Is 94% are correct, so we're 3 cohorts, non-comparative 3 cohorts phase 2 trial. The third one, this, okay, 100% exactly is the adverse event of special interest are hyperglycemia, diarrhea, and rash. Thank you so much, and I'm open for questions if there are some questions for the audience.
Thank you. Thank you very much. Коллеги, я хотела небольшой комментарий сказать про препарат.
I have a comment regarding this medication, the situation in our country, and then I have a question. In our institute, thanks to Novartis company, we performed a clinical trial on 200 patients for PIK3 mutation, and in the majority of cases we revealed the mutation. And now we see this presentation confirming our findings. This medication is not available yet in our country, and our country, some regions are participating in the MAP program, the program on the early access. And the patient that is coordinated by me, she is taking alpelisib. Professor Komen told us details, but which way to correlate hyperglycemia? You mentioned that 2-3 months it will be high and then it will decrease, but which way to manage that? Now we feel very doubting how to act in first 2-3 months.
So, can you hear me? Okay, so that's a very good question. First, I would like to add that I agree with you, and that a patient now should receive this drug, and actually the major guidelines indicate if you see in the flowchart of the algorithm of the luminal metastatic breast cancer, they suggest after progression CDK4/6 inhibitor to test for PIK3CA, for BRCA mutation, and then later we'll see also how this is important. So if you have a mutation, you know that this kind of treatment, the combination, is probably right now the most effective treatment for this patient. So we also know which are the side effects that we expect. And for the hyperglycemia, at least in our institution, what we do, we test weekly the patient to see the blood level, and of course we can intervene by reducing the dose if it's too high the level, or referring to a diabetologist and starting using metformin to reduce the glucose blood level. But at least in my practice, I never seen a very hard patient to treat regarding to hyperglycemia. Probably a little bit more rush with the treatment, but again, with antihistaminic, with the reduction of the dose, we have, this drug is manageable.
Thank you very much. Yes, we were thinking about reducing the dosage, but since our experience is small, just some patients can get this medication through the program MAP. Another option is to refer a patient to endocrinologists for consultancy. Probably endocrinologists can advise something. What do you think, dear colleagues? Everything depends on the level of hyperglycemia. There is metformin hydrochloride, and it is prescribed even to the patients with intolerance to glucose, 500 milligrams per night, and before going to bed. And there are many clinical researches showing that metformin decreases the number of cancer in those patients who take metformin in 10-15 years. So you can prescribe such medication in case of hyperglycemia. We have always a chance to determine a real exact level of hyperglycemia, and we can determine a real level of glucose, because sugar cannot always show the real level of hyperglycemia. So in this case, I don't think we're going to have side effects because the data of meta-analysis are routine and widely used. Metformin is widely used in different types of hypoglycemia and in patients with high tolerance to glucose. This is a well-known medication and has minimum side effects. And when you compare the efficiency and the side effects, of course, decreased dosage can result that patients may have less of efficiency because of dosage decrease. So I'm voting for aggressive therapy. I would prescribe the maximum dosage for the patient.
I have two questions. First, I agree with you. In SOLAR study, we do not have the information about CDK4/6 inhibitors. Now we start in Georgia clinical trial upfront together CDK4/6 inhibitors and PIK inhibitors as well. But if we upfront know that patient had PIK3CA mutation, which is preferable? Start with anti-PIK inhibition or start with CDK4/6 inhibitors? This is first my question. Second, I
have two questions.
Yeah. And second question, when the patient progressing on CDK4/6 inhibitors and we checked BRCA1, 2, and the PIK, and we have both mutations, what to do?
Okay, oh my gosh. Okay, so I will start with first. I think that you refer to the trial. You know, there are a couple of trials combining upfront PIK3CA inhibitor, CDK4/6 inhibitor, and endocrine therapy fulvestrant. But as the best I know, this trial includes patients who early progress on the adjuvant setting. So you have the progression during adjuvant endocrine therapy or less than 1 year, for example, the INAVO trial with the inavolisib. So in that specific case, that is a setting of patient with endocrine resistant or primary endocrine resistant or secondary endocrine resistant, probably we don't know yet, but probably the combination of the three, so blocking these three pathways, the cell cycle alteration and the PIK3CA pathway, we should not forget the PIK3CA pathway then act on the estrogen receptor pathway, and so deregulate the estrogen receptor pathway could be ineffective. Now, tomorrow morning, so we should not do that. PIK3CA mutation did not affect the efficacy of CDK4/6 inhibitors, while there are several preclinical data showing that the alteration of the pathway may affect the activity of the CDK4/6 inhibitor. There are several analysis in the clinical setting in the trial that show that there is no effect of the PIK3CA mutation on the benefit of CDK. So CDK4/6 inhibitor plus endocrine therapy remain the standard first line treatment. When the patient progresses on first line treatment and then you check for germline BRCA mutation and the PIK3CA mutation, I'm not sure about the overlapping of these two populations, but there are not agreed overlap, so there are very rare cases. In that case, I will check. It's hard to say, okay? It's hard to say, but this is my opinion. It will depend for the length of the duration of the first line treatment, because if you have probably a patient with a long time of treatment on the first line with CDK4/6 inhibitor, so an endocrine, let's call it still sensitive, I will keep with endocrine therapy plus the PIK3CA inhibitor. On the other side, I will choose a PARP inhibitor in the other case, but there is actually no data, not comparative data. The one that we know, the only data that we know that the earlier also the PARP inhibitor, you're giving the PARP inhibitor, the better, we have an effect. In terms of PFS, we have at this point similar PFS because in the Olympia trial we know that is a 7.2 months, 7.8 months. That was the same in the BRCA trial. So it's another question, but are both drugs that I will use before giving ADC or chemo.
Thank you.
One more similar question. It's very rare case, but in case in a first-line metastatic setting, if patient is HER2 positive but absolutely resistant to anti-HER2 treatment, we actually had this patient, and we tested for genetic mutations. We did NGS, and it was ALK positive. So we don't have any.
Was
ALK positive.
ALK positive.
Yeah. No,
The peak positive.
PIK3. Yeah.
Okay, PIK3.
CA positive, PIK3, CA positive. So we don't have indication of alpelisib in HER2 positive. So what would be your suggestion in real life?
Was in HER2 positive, right? No.
Was.
HER2 positive.
We retested, we made a rebiopsy, tested if it's really HER2 positive, but yes, it was.
Okay, no, but this is very important because in HER2 positive disease, 30% of patients with HER2 positive disease has a PIK3CA mutation. And the presence of the mutation is a mechanism of resistance to anti-HER2 therapy. So I am correct, so you say HER2 positive? Okay, yes. So, and actually there, and I just published also a preclinical work that's showing that when you have the PIK3CA mutation, you have are less effective the antibody conjugate, sorry, the monoclonal antibody anti-HER2, trastuzumab, pertuzumab. In the Cleopatra trial, patients that have PIK3CA mutation have a lower, shorter PFS compared with the others. So, and there was actually a trial adding alpelisib to the dual blockade that was stopped, but there is a strong rationale to add on the alpelisib. And actually now the only trial that is open with alpelisib is the Alphabet trial that is in the later line where they combine anti-HER2 therapy plus alpelisib in patients with PIK3CA mutation. So if you could do, you have to do it. you should add, you know.
So as I understand, we need to continue, despite the fact that it is resistant to anti-HER2. We still need to continue anti-HER and just
you can add on to the capture response. This will be something, you know, that I know that we can do it, but biologically and clinically will be the most effective way. I think.
Thank you very much, Carmen. Please.
So I'm going to present. Okay, so I'm going to present the next speaker, that is Tamara Esakia from Georgia. And she's going to present an age-specific pool analysis of trastuzumab deruxtecan in patients with HER2-positive metastatic breast cancer. Data from Destiny Breast 01, 02, and 03.
Good evening. I'm Tamara Esakia, a medical oncologist from Tbilisi, Georgia, Todua Clinic. First of all, let me thank the organizers for inviting me here. I'm really honored to be standing in front of you today. I'm especially happy to meet my friend Nazgul Omarbayeva, whom I have not seen since the pandemic started. So, I just want to add something that Dr. Irakli Kokhreidze said, that the 20% of Georgia is still occupied by Russia, but there are still good things in Georgia. Georgia is the country in which was born wine and Khvicha Kvaratskhelia. I couldn't resist saying this, Carmen. He's from Napoli. So let's start. My theme today will be an age-specific pooled analysis.
The QR code for the question.
Yeah, before starting, we will have the questions for you. So you can scan the questions. The first question is, what drugs from the group of antibody drug conjugates used in the treatment of breast cancer do you know? First answer is trastuzumab deruxtecan, second answer is trastuzumab emtansine, and the third correct A and B. Can I move to the next question? Next question is, what is the standard second-line therapy for the patients with unresectable or metastatic hormone-positive or negative HER2-positive breast cancer? First answer is trastuzumab deruxtecan, second pertuzumab trastuzumab docetaxel, and the third trastuzumab emtansine. And third question, what are the most common adverse events associated with the use of anti-HER2 drugs? First answer is hematological toxicity, second cardiotoxicity, and third nausea and vomiting. So, do we have the answers? For the first question, the majority answered answer 3 is C. For the second question, it was 2. Let me see if we will change this. And for the question 3, it was answer B. Now I will be presenting the age-specific pooled analysis of the HER2-positive metastatic breast cancer patients in the trials of Destiny 01, 02, and 03, which was presented on ASCO 2023 by Professor Jan Kropp from the Yale Cancer Center. As we know, regardless of treatment, old patients with HER2-positive breast cancer tend to have less efficacy and safety outcomes. Or the patients older than 65 are usually underrepresented in all trials, not only in Destiny trial. As we already know, we have the new standard of treatment, and trastuzumab deruxtecan is approved in the second line of metastatic breast cancer after prior HER2-based treatment or after neoadjuvant or adjuvant treatment. The outcomes of the older patients have not been studied thoroughly because, again, these patients usually are not represented in the clinical trials. So this pooled analysis was conducted to study the 3 categories of the patients: patients under 65 years old, patients 65 years old and over, and patients over 75 years old across the trials Destiny Breast 01, Destiny Breast 02, and Destiny Breast 03. Here are the representation of these trials, all Destiny trials. The first Destiny 01 trial was one-arm trial studying trastuzumab deruxtecan after progression on TDM1 or trastuzumab emtansine. Destiny Breast 02 studied was two-arm trials which studied trastuzumab deruxtecan versus treatment of physician choice, which included trastuzumab capecitabine or lapatinib capecitabine. And Destiny Breast 03 was the trial which studied on the second line of HER2-positive metastatic breast cancer, trastuzumab deruxtecan versus trastuzumab emtansine. And across all the trials, all HER2 positivity was studied and confirmed in the central laboratory. Here are the basic characteristics of the patients across the 3 trials and all the arms. As you can see, they were the majority of the patients, about 80%, were younger than 65, and the patients who were older than 65 were about 20%, and only 4% were older than 75. According to the ECOG performance status, the patients under 65 had the better performance status, and although these younger patients also tended to have the shorter time from the start of the HER2 targeted treatment until the progression and involvement to these trials. The patients were similarly had the similarity in HER2 positivity, also hormone positivity, and the percentage of visceral disease. Also, the older patients had slightly less de novo brain metastases compared to the younger patients. The comorbidities were low, and probably this is because of the strict eligibility criteria for the clinical trials, and they were more or less similar in the different age groups in the younger patients and older patients, although we had numerically more vascular disorders and hypertension in the patients older than 65, as well as mild to moderate renal impairment, which is probably the age-related changes. According to the prior therapies, the patients between the different age groups were similarly distributed, and also according to the drugs that were used before the involvement in the trials. The efficacy could not be analyzed across all the three trials summarized, because there were the discrepancies between the eligibility criteria in different trials. So it was analyzed separately for each trial, and as you can see, the light blue is for the patients who were younger than 65, and the dark blue is for the patients who were older than 65, and as you can see, the median progression-free survival was basically similar between the two age groups. Median overall survival was not met yet in the Destiny Breast 02 and Destiny Breast 03, but in Destiny Breast 01 it was quite similar between the two groups, 28.1 for the younger patients and 30.9 for the older patients. As the median overall survival for the Destiny Breast 02 and Destiny Breast 03 has not been reached yet, they calculated 12 months landmark of overall survival, and it was also quite similar between the two age groups. What concerns the objective response rates, which was calculated by blinded independent central review, it was also very similar between the two age groups. We can see in the light green the partial response rates, and in the dark green it's complete response rates, and across all the three Destiny trials they were quite similar. Probably the reason why the efficacy was so good in all the age groups is because the relative dose intensity was very good in these trials. For younger patients it was 98%, and for the older patients it was 97%, and to compare to the other trials it was quite good, and probably this is one of the reasons why trastuzumab deruxtecan has such good efficacy. And what concerns overall safety summary, it was quite tolerable across all the age groups, and the grade 3 or more adverse events were numerically low across all the age groups, but it was slightly more common for the patients older than 65 years old, and also we had a little bit more events associated with drug discontinuation for the older patients, although the reduction in terms of dose reduction, it was the same results between the two age groups. The drug-related deaths, it was low numerically. It was 0.6 for the younger patients and 1.7 for the older patients, and it was slightly more for the older patients, but still it's very low in the in all age groups. And what concerns more specifically the adverse events, the most common were nausea, fatigue, and vomiting, which is very common for trastuzumab deruxtecan, and in fact we had more nausea, fatigue, and vomiting for the in the group of young patients compared to the older patients. and the distribution of the adverse events in different treatment modalities was not quite similar. For the trastuzumab emtansine and trastuzumab deruxtecan, it was the same. We saw more grade 3 events in older patients, but in the we didn't see that in physician's choice arm or capecitabine trastuzumab or capecitabine lapatinib group. To be more specific about grade 3 and higher adverse events, the main difference was because patients older than 65 had numerically more grade 3 neutropenia and grade 3 anemia. So that was the main reason of the difference between the two age groups. And probably the most interesting and the most common adverse event for the trastuzumab deruxtecan is interstitial lung disease or pneumonitis, which we had more common numerically in older patients. Also, grade 3 and more was still very low, so there was no deaths, practically no deaths connected to the trastuzumab deruxtecan. It was a grade 5 events were numerically very low. Only 6 patients younger than 65 and 1 patient older than 65 and 0 patients older than 75. To conclude, the results from this pooled analysis indicate that trastuzumab deruxtecan is an effective treatment option for patients over 65 years old. Median PFS and objective response rates calculated by blind independent central review were similar for the trastuzumab deruxtecan in patients younger than 65 as well as in patients over 65 years old. Safety profile is quite acceptable across all age subgroups. Although, as we have mentioned, the patients older than 65 tend to have more grade 3 adverse events. Once again, these patients that were included in this analysis may not be the good representatives for the actual age groups that we see every day, because the patients who decide to be involved in the clinical trials or are eligible for clinical trials, it's not the big percentage of the overall population that we treat every day. So I think we need further research and real-world evidence to study and address the aspects of comorbidities, frailty, and age. And to summarize, trastuzumab deruxtecan may be considered as an effective option for patients across all age subgroups with an acceptable safety profile.
Now the question post.
Тамара, можно вопрос на русском? Я очень ждала ваш доклад. Вот с нетерпением больше всех
I
докладов.
would like to ask a question in Russian. I was waiting for your presentation because this drug is registered by FDA. It has very good profile of survivability, but in practice it has a lot of pulmonites. 15% it's a lot. Do you think when we have pre-medicated these patients with corticosteroids, antihistamine drugs before starting the treatment with this drug?
Actually, trastuzumab deruxtecan, I think, is one of the drugs that had very good results. It's the in Destiny Breast-03, the median PFS was 28 months compared to trastuzumab emtansine, which was 6.8, and it's quite a big step forward because the last standard of care was TDM1. And what we saw during these trials is that we have a lot of ILD, but I think we have to monitor closely patients first and not start treatment with corticosteroids. And if we have this adverse event, after that we should start treatment with corticosteroids, postpone the treatment, and sometimes if we have higher grade ILD, we just have to stop permanently treatment.
I agree. I just want to ask also the audience, you, Tamar, about. I mean, I don't like the separation between by age, 65 or 65, but about if a patient is a fit or not. Because in my experience, we can have patients. I'm treating patients of 8 years old that are super fit and that are just getting the drug with no side effect, no problem. Patient with 50 years old that actually has this kind of trial. So I think that the secret is also the close monitoring, but also the evaluation of the frailty of the patient with just starting in our clinic, just doing a simple scale, for example, a G8 scale that can help us to identify a patient that is frail or not. And if it's it, then to refer to a geriatric specialist. And we have in our center a geriatric oncology specialist that are specific geriatric for patients with this. And we found that actually reduce the incidence of overall the side effect and the adverse event of all drugs, not only TDXD, but this I think can help a lot. And this was interesting what the colleague said about the kind of pre-medicated patient to reduce there was. Actually, there is no data so far. There are data about the pre-medication for the nausea. It is also very important with the Raxetan. But I mean, it's an interesting point to maybe to address in a prospective trial to see if we can reduce the rate of the event. 2 minutes to do the post-test with the QR code.
I also want to.
I speak about pulmonite.
If there are no more questions, I also wanted to outline one thing. We have now we have trastuzumab deruxtecan in second line, but we have the patients who are heavily pretreated with TDM1, lapatinib, capecitabine, and sometimes they need the treatment in fourth line. So I think that we can, if you agree, we can use, if we used all the other drugs before and the patient needs to be treated, we can use in the later lines, like in fourth line. Actually, now I have the patient who is really heavily pretreated, who has medullary metastasis, and after radiation therapy, we started trastuzumab deruxtecan. On the first cycle, she came in the wheelchair, and on the second cycle, she came by her foot. So for the patients, I think for the patients who already missed their second line trastuzumab deruxtecan, we can use it in the later lines also, if you agree. So now let's come back to the questions. Question 1, what drugs from the group of antibody-drug conjugates used in the treatment of breast cancer do you know? Trastuzumab deruxtecan, trastuzumab emtansine, or correct A and B. Next question. What is the standard second-line therapy for the patients with unresectable or metastatic HER2-positive breast cancer? Trastuzumab deruxtecan, pertuzumab, trastuzumab docetaxel, trastuzumab emtansine. What are the most common adverse events associated with the use of anti-HER2 drugs? Hematological toxicity, cardiotoxicity, nausea, and vomiting. So these are the new results, yes?
So I will comment on the second one, because this is the toxicity, right? What are the most common toxicity, cardiotoxicity? But the second, I will add some comment on the second question that I think is the standard of care of second line, right? Can we go back to the one slide, please? From the previous one. Because I think that the answer was the previous one. Okay, by the way, it was the half and half that was TDM1 and TDX in trastuzumab deruxtecan, right? I think it depends where you live now.
I also missed this.
Pertuzumab.
Yeah.
Okay, but actually, from the let's say international guidelines, now the standard second line should be trastuzumab deruxtecan, and we can debate if patients have only brain mets and not extracranial disease. So in that case, an active metastasis, we know that tucatinib also is a very effective drug in combination with capecitabine and trastuzumab. So we can discuss about brain mets alone, but right now the strongest data is with trastuzumab deruxtecan. So I think that the standard second line treatment is the trastuzumab deruxtecan. So thank you so much, Tamar. I'm now I'll invite the next speaker, that is Juan de la Haba. He's all right here. Hi, Juan, a professor of oncology at the University of Cordoba, Spain. Can you hear us?
So let me read the question first.
Okay.
Instead of the speaker, because.
Okay, Professor de la Hava. So we are going to do first the small pool with the question and answer, and then I'll give you the.
So the question, the first question is, which patients are indicated for the determination of the germline BRCA1 and 2 mutation? A, metastatic breast cancer, early breast cancer. C is correct 1 and 2. The second question is standard of adjuvant therapy for patients with breast cancer and germinal BRCA1 and 2 mutation. Olaparib, talazoparib, and darucaparib. Third question is standard of first-line therapy for patients with HER2-negative, hormone-positive breast cancer and the presence of germline BRCA1 and 2 mutation. First answer is the PARP inhibitors. Second is systemic chemotherapy. 3 is immunotherapy.
Yes, very, very good questions all. Okay, I have to answer the question, or I have to hope the response. Sorry? Oh, okay.
Okay, so the first question was the 75% is answer C. It means both in the adjuvant and the metastatic setting. The second one, if the standard adjuvant therapy for patient. So second question. Okay, 94% choose olaparib, and the third one is the standard first-line therapy for patients with BRCA1 and 2 mutation, and 94, no, next one. Okay, 100% PARP inhibitor, but we will come back. I not agree with this as well. But we come back after doing the discussion. Okay.
Yes. In Spain, we have the same doubts. Maybe I think that the BRCA mutation is frequent when the hormone receptor has a low expression, and we have to see this if we choose well between olaparib and hormone therapy, and maybe cyclins inhibitors in the future. Is a very complicated scenario. We have not evidence to answer this.
Exactly. Okay, you can start, Professor De Haber.
Okay. I share the presentation.
Can they see the presentation? Okay, perfect.
Okay, thank you very much. Good afternoon, everybody. For the organizing committee for kind invitation to present the data of COMETA study. This is my disclosure of potential conflict of interest. And this poster was present in the last ASCO as a poster. Allow me to introduce to the most relevant aspect that support this clinical trial, do it by HEICAM. HEICAM is a Spanish investigation group that led us to make this type of clinical trial, proof of concept clinical trial. Tumor in BRCA1 carrier are more higher grade and the triple negative type, whereas the hormone receptor positive tumor are detected more often among the BRCA2 carriers. Triple negative breast cancer frequently show BRCA dysfunction. We know that the epigenetic silencing by aberrant BRCA1 or 2 promoter methylation can be responsible of the functional BRCA protein. BRC methylation occur depend of the different studies between 50 or near to 60%. It's very, very interesting, this question, because maybe the technical was used to determine the methylation. Is very important to go on in this way. The BRCA methylation breast cancer display a pathological feature and genetic profile like a germinal BRCA1 or 2 mutated breast cancer. Sorry. The third point that I think that's very important is that the olaparib. We know that this PARP inhibitor that show anti-tumor activity in germinal breast cancer mutation, HER2 negative, both in a advanced and adjuvant setting. An Olympiad study show that the objective response rate with olaparib is near to 60% based on the blind independent central review. Finally, with these issues, the COMETA breast study is a proof of concept phase 2 clinical trial to pretend to investigate the efficacy of olaparib in advanced triple negative breast cancer with BRCA methylation assessed in the somatic DNA in absence of germinal BRCA mutation. Yes, can you return the slide, please, to the objective? The previous. Thank you. The objective of the study is a phase 2, and the primary endpoint is overall rate response defined as complete response plus partial response according to the RECIT criteria. And secondary endpoint is the clinical benefit rate, it's the duration of response, progression-free survival, overall survival, and to evaluate the safety. It's known, but in this clinical trial we used to. And it's important, it's the main objective, it's an important objective, it's not main advance, it's important objective, the correlation between germinal BRCA methylation with the efficacy parameters. BRCA methylation between germline and somatic DNA, and the last is a BRCA methylation with an expression of the protein BRCA1 and 2. Next slide, please. Thank you. This is the outline of the study. We were able to include all those patients who meet the following criteria: advanced triple-negative breast cancer, having received more than one line of previous treatment, obviously not having received PARP inhibitors, and have at least one unmeasurable lesions. The central screening for germline BRCA1 2 mutation status and promoter methylation status for BRCA1 and 2 in the somatic DNA was performed. And those patients who only had BRCA promoter methylation were included, and the doses of olaparib in a standard dose of 300 milligrams twice daily orally. Next slide, please. Thank you. This is, in this two table, we have the baseline characteristic of the patient excluded. It's a total of 11 patients. Let me highlight a few of them. Relatively young patient, around 50 years. In our study, we found the methylation in BRCA1 more frequently, around the 65% of the patients, 7 patients. And the patient were mostly with high tumor volume, visceral involvement, 82% of the patient, and highly pretreated. Next slide, please. We have found of biomarker. We carry out a study of exome and complete transcriptome and a panel of 105 genes in a liquid biopsy in one patient who had very, very prolonged response without found a biomarker of interest by this moment. Next slide. Thank you. These are the results of the study, a median of olaparib treatment duration of 8 weeks, an objective response rate of 9%, only one patient of 11 patients included, and a clinical benefit rate of 36%, and a progression-free survival of only 2 months. These are negative results, and complying with the premise of the study, we stopped the recruitment. However, for our group, it was very interesting to find one patient with partial response lasting more than 20 months that continue today. We are currently looking for a new clues that guide us toward a new biomarker of sensitivity of olaparib in non-mutated patients. Next slide, please. Regarding to the safety data of the study, these are agreement with those published in previous studies, olaparib is very safety drugs, and it's possible to treat it for a long time, the patient. Next slide. This is our conclusion. The poster that was present in the last ASCO, olaparib did not show clinically and statistically significant anti-tumor activity in advanced triple-negative breast cancer with BRCA1 or 2 methylation non-mutated. This is a proof of concept. The results should be interpreted with caution. We think that it's necessary for a study to confirm this finding and to better understand the potential effectivity of the PARP inhibitor olaparib in this population. Thank you very much.
Thank you so much, Juan. We are going to, I think at this point, review the question. So please scan the QR code. And again, so the first question is, which patients are indicated for the determination of BRCA1 and 2 mutation? So is metastatic, early stage, or correct both settings? Second one is standard adjuvant therapy for patients with BRCA1 and 2 mutation. The answer are olaparib, talazoparib, or rucaparib. The third one is the standard first-line therapy with hormone receptor positive HER2 negative breast cancer and germline mutation in BRCA1 and 2. PARP inhibitor, systemic chemotherapy, or immune therapy. Okay, we can just a few seconds and then we can check the answer. Okay, so the first, okay, which patients are indicated for the determination of germline BRCA1 and 2 mutation? There is 90% of you that say correct both 1 and 2. I will say some exemption, but I know one already are laughing. We're talking about it.
We have 10% that don't change the opinion.
Okay. So standard adjuvant therapy, say olaparib, okay. And the third one is a standard first-line therapy. Okay, I think we have a lot to discuss. Okay, I will start first. Okay, then one. And thank you for your beautiful presentation. So actually, one, I have a question that's, you show in this proof of concept trial that the BRCA1 and 2 methylation is not, a predictive biomarker of sensitivity to the PARP inhibitor, to olaparib in this case. And so what do you think about potential other genes or other signatures that may predict sensitivity for PARP inhibitor?
Yes, I agree. I think that it's important to have a more global view of the genes implicating the reparation of DNA. In this patient, we do it the HDR of myriad, finding other genes, but not have a high HDR. I think that olaparib is more useful in other patients, but we don't know where. Maybe more genes is important to analyze this.
Okay. And then coming back to the first question, because we say that the question is that which patient indicate for the determination of BRCA1 and 2, and most all the audience were saying correct the both metastatic and the early setting. I mean, I agree. The point is that we need to effort, if we imagine to test 2 million of patients every year globally for the BRCA1, I think it is not affordable. So my suggestion is first to check for the criteria of the the presence of family history. So checking patient in an early stage with the family history. So, and then you can, that are more at a higher risk of having actually a mutation, or those patients that meet the criteria of the Olympia trial, rather than try to test everyone. In the metastatic setting, instead, we can test for sure all the triple-negative breast cancer and all the luminal breast cancer, but we know that if you have a patient with a luminal metastatic breast cancer that does not have a family history of breast cancer or hereditary breast cancer, you have the predicted negative value of the test that is around 99%. So we expect to see a negative results. How do you do in your clinic in Spain, Juan?
In metastatic breast cancer, we have a regulatory problem because in Spain, olaparib have not possible to use for regulatory.
So you're not going. Okay, so you're not using the.
But I think in adjuvant is different because the result impact in global survival, and I think that.
I see.
I think that they will go on to get BRCA mutation in all the patients, high risk and low risk. I think we have to get it.
Okay. And the last question was the answer. I think we missed one answer because the standard first-line treatment for patients with ER-positive, HER2-negative metastatic breast cancer with the germline mutation, I think is not PARP inhibitor. What do you think? Because I mean, there are data now that show that probably patients with this mutation have a lower benefit from CDK4/6 inhibitor. I think mostly due to the mutation in BRCA2, because if patients have a mutation, a deletion in the BRCA gene, you also have a deletion of RB1, that is a mechanism of resistance to the CDK4/6 inhibitor. But I think that still patients with a mutation should receive CDK4/6 inhibitor in the first line. What do you think?
I think that it's we have to take account the intensity of the expression of the hormonal receptor. In the Olympia, in the adjuvant setting, BRCA mutated is associated with a low expression of hormonal receptor, and I think that is very important to take account this. Maybe in metastatic breast cancer, the first line is CDK inhibitors. Neoadjuvant is a problem. What do you use? CDK inhibitors, thinking about the Monarchic or Mona Lisa, or use an olaparib. I think that we have take into account the level of expression of the hormonal receptor, but I'm not sure.
Okay, thank you. Thank you so much. Are there questions from the audience? No question. Thank you so much, Juan.
Thank you for all.
Коллеги, следующий спикер будет докладывать на английском.
Next speaker is going to deliver his presentation in English or in Russian. In Russian.
На русском языке это наш большой друг.
This is a big friend of us, Dr. Maya Jugashvili from Madrid, Spain, a radiation oncologist, MD, PhD, Genesis Care Madrid, ASTRA and SC, with her topic oligometastatic breast cancer, bridging the science with patient preferences.
Вы на связи, Майя?
Здравствуйте, да, я на связи. Спасибо большое за приглашение.
Thank you very much for inviting me. I will share my screen.
Вот так, все видно, да? Да, поскольку слышно меня?
Can you hear me well? Yes, we can see, we can hear well.
Поскольку мои слайды на английском,
Since my slides are in English, I keep it in English, but I will speak Russian. it will be faster. And I hope I will have better contact to understand each other. So there are 3 questions for my presentation. First, let's discuss the questions. So, since I understand the audience is going to vote, the first question is, what is the best definition of oligometastatic disease? Please choose one of 3 answers. The availability of 1 or 3 sites of metastatic disease, irrespective of number of organs affected. Another option is from 1 up to 5 sites of metastatic disease, irrespective of number of organs affected. Could be in the same organ as well. Or a third answer, from 1 up to 5 sites of metastatic disease in the same affected organ. Are you going to vote? Yes, but please do not tell us the correct answer, because at the end you will show us again the same questions and we will double check the answers of the audience. Are you voting in the beginning? We vote both times, in the beginning and by the end. So, second question. Second question. Which of the following statements is false? Oligometastatic disease is associated with longer survival versus polymetastatic disease. Second statement is, more frequently TNBC happens than HR plus and HER2 plus subtypes. Third statement is, more often it is identified incidentally than symptomatically. So, which is false? So, the second statement is showing the clones that are suitable for treatment. And the third statement is about the metastases that are widely spread. Now the third question. The third question is, what do we know about our patients with oligometastatic breast cancer? Is it associated with the general life duration, or there is a comparison between oligostatic versus polymetastatic disease? Mainly, there are receptor positive instead of triple negative breast cancers. And mainly, it is found absolutely incidentally versus symptomatic diseases.
Проценты мы можем вывести, да, сюда?
Can we please see the percentage?
Все, Майя, вы можете начинать лекцию.
So let us start your
Мы к этим
lecture,
вопросам еще
and
вернемся
we
в
will
конце
get
вашей
back
лекции.
to these questions by the end of your lecture.
Okay.
Let's start from analyzing the randomized research effect on the patients who provided their participation. Please turn on your slides.
Все в порядке, можете продолжать.
Okay, let us continue. Let us recollect. We speak about oligometastatic disease of the breast cancer. This randomized searched on the oligometastatic breast cancer patients. These are heterogeneous countries like India, Turkey, Dutchland, US. They applied similar regimens. In the Indian case, they applied 6 cycles of chemotherapy and then applied local therapy, including surgery and the underarm pit nodes removal. So they wanted to show what is better, systematic therapy versus local therapy. Local therapy includes surgery and radiotherapy. In Turkish and in Dutch case, they did not provide chemotherapy, just surgery and radiotherapy if it was prescribed after surgery. There was a mastectomy and lymph node in the armpit removal. In the Dutch study, also, there was no chemotherapy provided. There was a surgery and radiotherapy provided. In US and Canada researchers, there were from 4 up to 6 most optimal chemotherapies provided and applied only in case of early stage. Japan applied 3 cycles of optimal chemotherapy, and they provided local surgeries without lymphodissection and no radiotherapy. In Austria, there was no systematic treatment, just surgery and sometimes radiotherapy. In this slide, you may see the data from Indian randomized research from their hospital, showing there was no significant difference between the patients who had systematic therapy versus local therapy. So results were absolutely same. In case of oligometastatic breast cancer, they proved that local treatment in those patients are giving no difference, no benefits. Also, the overall survival in this case was 54 months. Again, no difference between different groups. Regarding details of subtypes of breast cancer, so triple-negative breast cancer was responding worse instead of hormone-positive breast cancer. Here is the citation saying that the biologics of tumor is the king. So the choice of therapy, it's up to the patient, and technical maneuver and approach is like a prince or a princess. So it is saying that sometimes prince or princess is trying to get the throne and they want to become the queen or the king. But results are still same. Queen or is getting the throne means the choice of therapy is the fundamental. This is the basic. The molecular biology, the genetic subtype of the tumor, and then we can make a choice, and only then to prescribe different approaches for treatment. Since I'm the radiation oncologist and I study the oncology, we have different patients. We apply multidisciplinary approach. Sometimes I travel to different disciplines, so the overall survival depends if there was a stereotoxic radiation therapy applied. We call it Saber comet. in patients with oligometastatic breast cancer. Here you see the significant difference in patients who got the ablative stereotherapy and in those who did not have that. In this case, they took absolutely heterogenic tumors, including prostate, breast cancer, and colorectal tumors. In this slide, you may see that there is a separate group of oligometastatic breast cancer with a stratification depending on metastasis and hormone receptor status, HER2 status, and depending on chemotherapy. In one part, the patient got palliative care only and standard therapy. In other group, in the other arm, they got stereotherapy and standard therapy. 80% of those, they were hormone-positive patients, and in 72% they got ET without chemotherapy. So now the results are having no difference. So those who got stereotoxicity together with chemotherapy, they lived 2 months longer. And here is the significance. So stereotoxic radiotherapy in case of breast cancer does not play the role, also because the breast cancer is having high potential for metastasis, for metastatic distribution. And of course, if we impact only locally, we cannot stop breast cancer. Of course, first of all, the key and the main role is for the systematic therapy. Take into consideration that contemporary treatment, immune therapy, and target treatment, everything that we do not have available against breast cancer, they can help. And in case of multiple metastases and with the radiotherapy, but stereotoxic therapy does not play any role. Here is the phase 2 of randomized study for oligoprogression. Depending on histology of breast cancer, there was randomization provided. In the first arm, there was no stereotoxic radiotherapy. There was only systematic therapy. In the second arm, there was stereotoxic therapy, and there were metastases found. Here you see that only those who got stereotoxic therapy, they lived 2 months longer only, comparing to those who did not get stereotoxic radiotherapy. So even stereotoxic high-tech therapy does not play the key role. Still, the key role is for systematic chemotherapy. Let's discuss the cases to show you which way we should impact in different cases. In the first case, you may see a woman, 36 years old, who found herself in the left breast some node, and then there was a monographic study, and 5 centimeters mass was found, and I also suspected the left armpit for the node. The ultrasound biopsy showed that this is a receptor negative and HER2 positive breast cancer, ductal carcinoma of grade 3. and biopsy of lymph nodes in the armpits proved that it was defected with metastasis, and patient suffered from the back pain, but she was explaining that she's carrying small baby all the time. First of all, the primary study showed this woman is having a 3 millimeter node in the liver, suspected for metastasis, and sclerotic node in the spine. It was very difficult to understand what kind of that. And the test results were normal. We performed the liver node, and it proved the carcinoma, and there was a grade 3, ER negative, HER2 positive. So here is a question, what to choose? Shall we choose a patient for surgery, for breast resection, and for the metastatic tumor in liver? Or shall we start with medication, or shall we localize with L2 in the spine? So, what they have done? The patients started with a systematic treatment with good toleration, and when there was a first study, after 3 months, it was shown there is a decrease of the liver tumor, and in the spine, L2 was stable, so it was decided it was not microstatic, and underarm lymph nodes were not detected anymore. So, should we still her send for surgery or not? So, what have been done? It was decided to maintain her with systematic therapy. Patient felt well. She started to work. 4 years passed, and she got systematic therapy and no complaints anymore. But after 4 years, she paid attention to the changes in the left lateral part of breast. And there was a biopsy made and proved that the primary tumor relapsed, but no distribution. Initially, there were some positive accumulation of contrast. This time, there was no accumulation. So would you change the systematic therapy, or shall we send her for surgery? Do you agree or disagree? Do you vote for surgery, or you are against surgery? So what has been done? After the discussion with the patient, it was decided for surgery. So they made mastectomy. What is the role of the surgery? What are the roles of surgical margins in case of resection of lymph nodes? And when it's possible to make the breast reconstruction after mastectomy? And here is the answer. The patient got a mastectomy with the reconstruction of the breast at the same surgery during the same procedure, and anatomic test showed residual metastatic carcinoma, keeping the initial biology. Receptor negative, HER2 positive, and clear surgical margins. In this case, shall we prescribe adjuvant radiotherapy? And does she continue systematic therapy? What do you think? Nothing has been done. And the patient continued to make systematic therapy. 3 years more passed, and the patient asked to stop the systematic therapy. She asked us, can we stop systematic therapy? What do you think? So it's up to you to decide. So case number 2. A woman, 59 years old, with the hypertension, manageable hypertension. She was diagnosed with a ductal carcinoma, dual carcinoma, ER/PR positive, HER2 negative. Second stage, third grade. Diagnosed 4 years ago. Same time, she got the conservative surgery on the right breast, and in the neoadjuvant, she got 4 cycles of docetaxel together with cyclophosphamide, together with radiotherapy and hormone therapy. She was complaining during 3 months of pain in the hips. So there was a research made, X-ray was done on the hips, and there was a sclerotic change of 1.5 centimeters in the head of the right side hip bone, and it was suspected to be malicious. So PET computer tomography demonstrated accumulation of the contrast that was the head of the hip, FGD consumption, active consumption. So the blood test was absolutely normal. The only thing is that alkaline phosphatase was elevated. What do you think? Should we make biopsy, and is it important to prove a diagnosis? What has been done? They performed a biopsy in the joint, and it proved also adenocarcinoma of the breast, receptor positive, HER2 positive, but doubtable. So they made FISH, and it showed HER2 negative. She was consulted by orthopedic specialist, and she got the result there was no risk of pathologic fracture. So there is a multiple choice what to do with such a patient. Shall she be sent to systematic anti-tumor therapy with fulvestrant together with the CDK4/6 inhibitors and with the cedifluramine acid?
У меня больше не переключается. Вот сейчас. Да, я извиняюсь. Значит, имея в виду то, что...
So bearing in mind that she had pain syndrome because of chemotherapy, can we apply radiotherapy? And can we start zoledrone acid? Still, the patient got, first of all, the therapy against the pain syndrome, tramadol, 50 milligram each 8 hours when necessary, and we started fulvestrant therapy together with CDKI4/6 and 3K. She was tolerating that, and there was PET after 4 months. What would you do in this case? Would you send her to the oncologist, or only in case she would have symptomatic expression of the disease? or probably you would send her to a specialist in case of the doubtable response. So it's up to you. So she continued the therapy. She was not sent to the radiation therapy, and PET scan after 1 year showed there is no metastatic disease. So, still a question, shall we send her for consolidating radiotherapy, or shall we send her for different regimen of therapy? She continued to take fulvestrant together with the CDK4/6 inhibitor, and after 3 years after PET therapy, PET did not reveal any signs of the disease in the bones, but there were signs in the liver. Shall we change something in the therapy? The patient tolerated well the therapy. She was extremely interested in the opportunity to control the tumor locally. So the question to you, so should you prescribe the local therapy, resection, radioablation, or any other methods of the local control, like embolization or the stereotoxic radiotherapy? So we were thinking over if you would find out that metastatic tumor is developed in liver and developed in the lateral part of the breast, so you would send her to the surgery. So, what they have done in her case? This patient was discussed in the multidisciplinary conference, and she was referred for the radiofrequency ablation for her metastasis. And 6 months later, she was showing no relapse. But 13 months later, when PET showed, again, there were 5 new bilobar metastases in liver. So therapy was changed. What are the summaries? Multidisciplinary approach is absolutely necessary in discussion of such patient. Sooner better to start treatment. And regarding oligometastatic cancers, it is frequent includes multimodal therapy. Currently, there are all results provided, they are very limited, and they do not show any benefit for general disease, and mainly the main role for the palliative care and for the maintenance of the life quality. So now, shall we think about biomarkers of the real time? For instance, ctDNA. Is it applicable? Should it be based on the genetic analysis and biomolecular science? So, should it improve results together with high efficiency of systematic therapy? And do we need clinical researches, clinical trials, take into consideration the biomolecular basis for these subtypes of diseases? These are the questions and summaries. Thank you very much, Maya. I was very much pleased to listen to Maya, because we should provide the definition for the oligometastatic disease. So, what is the definition? This is the intermediate condition between dissemination and local process. 3 metastases can be considered as oligometastatic, or it can be disseminated polyprosis, depending on localization of the metastasis. In case of colorectal cancer, in case of 3 metastatic, it will be considered as oligometastatic. But vice versa, if one metastase in liver, another metastase in lung, and another metastase in colorectal area, so this is dissemination phase. So this is a definition of oligometastatic cancer. So it's in between, somewhere in between. This is a question for organizers. When we speak about oligometastatic cancer impacting locally, good example is colorectal cancer with the same metastatic in lungs. For instance, there is a systematic treatment and then progress 2-3 small metastases in lungs. And this should be a local treatment provided. But before, there should be 2-3 times of chemotherapy, not more, because the surgery in the later phase is improving results. So in this case, we can make 3 courses of treatment and then surgery, and this is the local treatment. Another case, in case metastases are in the brain, together with the adenocarcinoma in lungs. Good results are shown in case of therapy depending on mutation, in case of ILK or GFR adenocarcinoma. To exclude the impact, in case there is only 1 metastase in the brain, and if there is a neurological pathology, and resection of this metastase would help to decrease risks and would improve the hematoencephalitic barrier penetration, then we can prescribe radiotherapy. So when we speak about oligometastatic cancer, we should give a strict definition. So this definition was introduced only in 1995 by Hellman, and there was a theory developed for oligometastatic cancer, because in some patients, even with metastases, or when we provided additional local, regional, systematic treatments, we got good results. And those patients, despite metastases, lived for quite a long time. And this definition was applied in 2 localizations, prostate and breast cancer. Regarding breast cancer, still, I believe that oligometastatic breast cancer is different, because the oligometastatic breast cancer is a classical systematic cancer disease, because cancer diseases are very different. It's not a disease just for one organ. This is the whole body disease. Lymphogenic, hematogenic, one prevailing another. And regarding breast cancer, in case of progressing, in case of smaller metastases, first of all, we should start with a systematic treatment. And there is a big question: should it be local and regional treatment? Even in case of metastasis and pain, you can prescribe zoledronic acid and NPVS, and pain syndrome will be removed. No other impact required. So this question should be differentiated, and definition of oligometastatic cancer is very vague. No one knows where is the border. So this is just by intuition you decide, because we cannot judge by the number of metastases. Sometimes metastases are in liver. It could be bilobar distribution or in one lobar of the liver. If there is a bilobar location to metastasis, you would not be able to make hepectomy. But in case metastases are located in one lobe, you can make surgery very clearly. So you can differentiate that. And Maya mentioned very much correctly, one head is good, but many heads is better. So we should practice multidisciplinary approach. Without morphologists, we are nothing, and we are nobody, and we have no names, because all the oncological diseases are having morphological substrate, and this substrate can be changeable with the time. And due to the hormone dependence, we can get ER2 changes. So all patients should make biopsy in order to understand, is there any mutation, or maybe there is a new localization. For instance, in case of breast cancer, there could be a formation in the lung. Maybe this is a peripheric disease, or maybe these are metastases. You never know. So that's why biopsy should be made. So the final diagnosis can be made in the multifaceted approach. And without morphological research, we cannot. The best oncologist is pathomorphologist. Our discussion was very interesting. I'm very much thankful to Carmen, and I love his family name, Angel. And Angel is angel in any language. I'm very much thankful for your participation, and lots of questions we clarified. We thank you for that. I also would like to thank Maya. It was a very interesting report, and I like the slide explaining the principles, saying who is the queen, who is the king. It explains the strategy to take in case we discuss difficult cases. Thank you for your case as well. We are finalizing this section with the satisfaction, with the deep knowledge. And let me invite you here for the group photo.
Go to group photo. Carmen.
Dear Carmen.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with the heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. KazCS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.